Okay.
Haven't got any gags.
Being recorded, Gerry.
Oh.
Yeah, that was me. I pressed start webinar, so I'm hoping that it's actually starting now. I just moved Matt from backstage as well because he was backstage like we were.
Oh, hello, Andy. Nice of you to join us.
Hi, everyone. Oh, we've got a minute to go. So let's, yeah. And I think, is anyone else in the, oh, hi, everyone. See.
Andy, is there anybody else who should be a panelist who isn't that I need to add? Or have we got everybody?
Yeah.
Matt Franklin, I think.
Matt Franklin, yeah.
Matt says he's having problems. He's now locked out of Zoom, he thinks.
Oh no.
So I'll let you know if I find out a bit more.
Clara, if you let him know if he wants to join as an attendee, I'll keep an eye out for him and then I can promote him up to a panelist if he's having problems with the panelist link. So we have 24 attendees currently, so we'll give people another couple of minutes to join and then Andy, over to you, I think.
Thanks, Katie.
Right, Katie, I've just moved Matt Franklin to the main webinar because it's backstage.
Thank you.
Yeah, I think there's some questions about cameras on. As I understand, it's just the panelists that have cameras on for the event. So that's probably why people might not be able to turn them on. That's just how
That's right. So if we've got any questions later on that people can't put in the chat, we can promote you up to a panelist so you can ask it, and then it's a bit less complicated than doing it in the chat.
Actually, Katie, you can allow people to talk on the attendees list. There is an allow to talk button.
Right.
I've just sort of been having a look around while I was looking for Matt Franklin.
So yeah, I'll just give people another couple of minutes and then we'll get going.
I'm not sure I've ever seen so many health economists on one Zoom meeting. This is quite a gaggle, isn't it?
Yeah, what is the collective noun for health economists? An intelligence of health economists.
I thought we usually say confusion, don't we?
There was a
Confusion.
debate about that on Twitter, and there were much ruder words than that
Yeah.
used. I won't share them publicly.
Okay. Okay, we can probably kick off, I think. So, hi everybody, I'm Andy Clegg. I'm Professor of Geriatric Medicine at the University of Leeds and a consultant geriatrician at Bradford Teaching Hospitals, and it's a A real pleasure to have you all here today for this event focusing on multi-sector economic evaluation in ageing research. I'll just spend a couple of minutes just giving a bit of orientation for people in terms of the background for the work. So for the event. So the event's been organised as part of the National Institute for Health Research Applied Research Collaboration, the NIHR ARC Ageing, Dementia and Frailty National Priority Theme. So I know that some of you will be familiar with the ARCs and what they do, but for those of you that aren't, the NIHR ARCs are regional programs of research, applied health and care research, with a big focus on implementation of research into practice. And they address the needs of local and regional priorities, but also national priorities. And ageing, dementia and frailty was identified as a key national priority. And so for 4 of the ARCs, Yorkshire and Humber, Wessex, Greater Manchester and the South West Peninsula Group provide leadership for the national priority theme. And as part of that, we've been putting together a series of learning events focusing on key areas of interest for people working in this ageing research community, but also looking at it from a policy and commissioning perspective. And I know there's quite a range of people on the event today. And so we took a lead on this between ourselves in Yorkshire and Humber, and Chris Todd, who leads the healthy ageing theme in Greater Manchester. We suggested taking leadership of this theme because we've got a huge amount of health economics expertise in both of our regions, Yorkshire and Humber and Greater Manchester. Leeds, York and Sheffield over in Yorkshire and the Humber, and Manchester University in Manchester. So specifically over at our side, Laura Bojke and Tracy Young lead our health economics theme in our ARC, and are also part of the National Policy Research Unit for Economic Evaluation. And then Matt leads the NIHR ARC health economics theme. So we've got a huge amount of expertise, and we thought that focusing on ageing related research, with all the complexities involved, the sort of multi-sector nature of the evaluations that we think about, and the complexities of the group themselves, older people and their particular needs and priorities, alongside their needs sometimes for the carer perspective, meant that we've put together, I think, a really interesting series of talks for you today. And it's been really good fun putting it together. Actually, it's been a really great group to work with, and I've really enjoyed it. So big thanks to everybody for the help putting the program together. So I think it's going to be a really fantastic few hours. Just before I hand over to Seb, who's our first speaker, just a bit of housekeeping. I mean, all your screens off, and I think we'll have presenters, other than the presenter presenting, we'll have all the panelists' screens off during the presenting. If you put your questions in chat, please. What we'll try and do, we've set aside a bit of time at the end of each talk for some questions, but if we don't get time to answer them, we have got a panel discussion later on that will try and bring forward some of the key questions into that as well. So I think hopefully there'll be time to answer the questions. And if the panelists can pick up questions that are simple to answer with a quick answer by text as we go in the chat, that's probably the easiest way to do it. So if you've got particular questions for particular presenters, then maybe put their name at the start of it. We're planning to record the session and make it available. I don't know if you started recording, James and the team. And also what we thought we'd do for this session particularly, where are we? We're going to put in a glossary of terms now, just so that people can refer to them. I suspect people will have come across most of the things that we're talking about, but we're not going to go into the definitions of single thing that we cover today. So instead, we thought we'd give you a glossary of terms that I've just put a link to. This is put together by the Health Economics Consortium based up at York University, and I think it's really useful. And we're also just going to give brief intros to the speakers, just sort of name, position and institution. So if people want to know a bit more about the speakers, I'm also just going to put in the chat links to their university web pages. We thought that would be the easiest way to do things, and they've also got links to email addresses and things there. So without further ado, I shall hand on to the first speaker. So Seb Hinde is a research fellow up at the Centre for Health Economics at the University of York. And Seb's going to give us a bit of a background in terms of the principles and the origins of economic evaluation. So an overview of that area. So over to you, Seb.
Sorry, age-old problem. I shared my screen before demuting and then couldn't remember how to demute once I shared my screen. So let's start again.
No worries, Seb. You're in good company.
So, can you see my screen?
Yep.
All right, and you can still hear me, I'm guessing? Lovely.
Yep.
So, thank you, Andy. So, as Andy said, my name's Sebastian Hinde from the University of York, and I'm a research fellow at the in the Health Economics Equity and Health Economics Equity and Evaluation theme at the NIHR ARC Yorkshire and Humber. And I'm going to be giving a bit of an overview on the principles and origins of economic evaluation in something like 20 minutes. So probably hold on to your hats if you're new to economic evaluation. So just some quick fundamentals. The aim of this presentation is just to give an overview of some of the intuitions and practical applications of economic evaluation, and hopefully to get everybody in the audience thinking and ideally questioning the approaches. I'll try and avoid lists of definitions where possible, leaning more on intuitions, but if I've learned anything over the last couple of years, it's what intuition means to one person is very different to another. A lot of what I cover is rooted in what's conventionally known as the NICE approach to economic evaluation that's sort of become synonymous, but there's a lot more. And I'm aware that even in that bullet point, I've already had two acronyms that some people might be slightly unaware of. So there are many rabbit holes, as there are with everything around economic evaluation. Some are explored later today by my colleagues, some won't be, and some really are yet to be fully explored. Whenever these rabbit holes pop up, I throw up this image, largely just to defer the point so that you'll have a lot of questions coming up at those moments, and they're very important to have and to keep in your brain. Economic evaluation, it always slightly surprises people, but it's very much still an evolving discipline and has been since it sort of created in the 60s, 70s, depending on when you want to put the flag in. But a lot of people argue that it's become very sticky as it's become more engaged in policy, trying to update methods and sort of change things has become increasingly difficult. So for anyone that's ever read a health economics evaluation of sort of an RCT, a randomised control trial, or a new pharmaceutical considered by NICE, this might be the sort of statement that you've seen before. The ISA was £22,000 per QALY, which is above the lower bound for what NICE considers cost effective, but below the upper bound. However, when the PSA was considered, there was significant uncertainty, as shown on the SEAC. As a result, a VOI analysis was conducted, which indicated a high EVPI, with the EVPPI highlighting the probability of regression being the most significant factor. The health economists in the audience will hopefully be nodding along that that's something that they understand. You could sort of follow along with the logic of that, but it's far from an accessible statement otherwise. Similarly, there's reams of terminology and acronyms that pop up whenever you see economic evaluations reported that rarely come with sort of clear definitions, and in reality it's very hard to cover all of the definitions that you need to cover in a single paper or a presentation. But while the modern applications of economic evaluation in health can be inaccessible, the fundamentals are really as old as the hills, seeking to address age-old questions of the justifiable expenditure to save life or improve health, while being aware of some of the alternative benefits of that sort of spending. So this is a quote from the Saturday Review from 1871. What is the fair average value of a human life? Would it be right to spend £100 on a head in order to save them, or 1,000 or 1,000,000? The lowest of these sums would obviously be too small. The highest would be too great, if only because the same amount expended in different ways might do infinitely more good. So that's really the key underlying principle of economic evaluation as it stands. How much is it worth to improve life or to save life, and with a sort of mind to how else that money could be spent. But in reality, it's never easy, and that even though this has been in people's considerations for a long time, it's not been resolved. So to be trained in medicine, nursing, or one of the other sharp end disciplines, and then faced with some hard-nosed, cold-blooded economist placing money values on human life and suffering is anathema to many. And my wife would very much agree to that. She's a obs and gynae registrar. So I always think it's a good starting point to anyone new to economic evaluation, or really that has become a bit jaded by it, to go with Alan Williams' quotes, who's one of the founding fathers of modern economic evaluation. So he said there are far more potentially beneficial healthcare activities than any country can afford. Therefore, some potentially beneficial healthcare activities have to be withheld. If someone says to me that they must have something no matter what it costs, I take them to mean that they must have it no matter what the sacrifices have to be made. And it's always easier to make such statements if the costs or sacrifices are going to be borne by someone else. And I take the objective of cost-benefit analysis, so economic evaluation, to be to assist choice, not to make choice, not to justify past choices, nor yet to delay matters. And finally, he very much viewed health economics as the cheerful face of the dismal science. So these quotes paint a simple framework of what economic evaluation should be aiming to do, although not necessarily what it always does. It's to reflect the full implications of a decision, both the observed and unobserved impacts, and doing so to inform and assist policy, not to make the decisions. So why do we even bother? And not just in health, but what's the underlying idea between economic evaluation in any setting? Put simply, it's an assessment of value, but the key is what is value and whose is it? And importantly, what is the value of the other things that we could have done if we didn't do the new thing? So the main principle is that we can't do everything. So how do we measure the value of what we do and what we have to stop to do it? Building on that principle, what can we do and say of benefits to policymakers and stakeholders? So I always try and encourage people, whenever they're doing economic evaluations, keep these general questions in their mind. Who are we talking to and about? So funders, taxpayers, patients, families, or everyone in society. What's their underlying aim of the people in their different contexts? So are they trying to minimize costs, get the most of some outcome, save lives, doing so in a fair way, or to some sort of minimum standard? And how do we measure these aims and the costs of achieving them? So we're talking about measuring long life, healthy life, fairness, economic growth, happiness, well-being, personal wealth, or all of it. And they all have very different implications for how we proceed. So let's go back to intuition and think about the displacement of sweets. So a fundamental truth is more money means more sweets, means more happiness, whether that's for children or grown-ups. If a child had 10p, he'd be able to buy 10p of, say, 1p sweets. So he'd buy this set of sweets. But if he also wanted to buy an ice cream that was 2p, then quite simply, if he put it in his basket, he would have to stop buying 2 of the other things. It's a very simple idea, but one that sort of holds true in economic evaluation of health as well. So let's stick with the idea of sweets just for simplicity for a moment. So pretend that we're back in the days of trips to sweet shops, and I know a lot of people will now be imagining what they would have done with their money back with the last time they went to a sweet shop. I won't judge whether that was recently or not. What sort of things would you consider and why? So it'd be the costs of the best sweets, the enjoyment that you get out of the newest sweet compared to what you'd normally buy, and what could you have done with the money otherwise? More sweets, something else, or the milk that you actually promised to buy. So these are sort of 3 fundamental principles. It's the costs to consider, the benefits of what you're doing, and the opportunity costs. So the benefits of what you would have done otherwise. So how about if we apply this idea to health? Pretend you're an omniscient commissioner of healthcare in a very neat sort of public funded system with no caveats at all, and you're looking to buy healthcare services for your population. So let's think about the 3 things again. The costs to you of, say, the drugs that the pharma company is selling compared to the generic. The amount of additional health benefit it's likely to entail, informed by sort of a randomized control trial or something. And then what else you could have spent the money on. You might have to sell the machine that goes ping, which is a reference that some people get and some people don't. So how do we frame these? So again, let's go back to the costs of the different care options. Consistent with the idea of a single healthcare commissioner, Conventionally, economic evaluation focuses on the costs of the NHS and personal social services in England and the UK. So a few things to consider. I won't go into detail about how you do all these costing, because that would be an entire day's worth of quite dry lectures. But you have to consider the upfront cost of the treatment, so the drug or the surgery costs, and then also the long-term cost implications of the different forms of treatment. So things like increased hospital visits with one drug over another. These are often split into the resource use implications and the unit costs, where the resource use is just how much of something the patient uses. So how many times did they go into hospital, and the unit cost, which is just the cost of each additional bit of care. So one prescription or a GP visit. Conventionally, all other costs are then put to one side. So things like out-of-pocket costs of the patients, other public sectors that bear a cost, or private sectors. But again, this is an enormous rabbit hole that I won't go too deep into. So then the second part, how do we value health? So the benefit of funding healthcare interventions. In specific diseases, you might have clinical outcomes, so things like blood sugars or CD4 counts in HIV, or a hospital might have administrative targets, so readmission levels or delayed transfers. But they aren't strictly health as sort of the public would imagine it. So if you talk to someone about what the NHS is funding, it wouldn't really be a focus around blood sugar counts or reducing readmissions. It's about improving the whole population health. So we had, years ago now, the idea of generic health outcomes were developed, which were outcomes that could be used to try and grapple with this idea of what is health and how do we put a number on it. And many of you will have heard of the EQ5D, which aims to tell us about the quality of life in very general terms. And then it can be combined with the length of that life lived into a quality adjusted life year. So just an adjustment for how long someone's going to live on the quality of it. So a QALY. But again, very big rabbit hole. So I thought I'd quickly give everybody an overview of the most common generic tool that's used to measure health, which is the EQ5D3L. And it's still the one that NICE recommends as of this year. It's been largely unchanged since the 1990s, which is sort of a benefit to it because it's incredibly sort of ingrained in economic evaluation now. The questionnaire has 5-part descriptive system, each with 3 levels, and I'll show you a picture of what it looks like in a second. As a result of these 5 parts with 3 levels, you end up with 243 different health states. And then you can have valuations of country-specific tariffs to generate the QA bit in the QALY, so the quality adjustment. In the UK, these scores give a value between -0.594 and 1, where 0 is the equivalent to death and 1 is the best health imaginable. There's been a recent shift to a new version of the EQ5D, which is the 5 level, but NICE still aren't sort of going with it as their approved method. So this is just a quick show of what the EQ5D3L looks like. So you can see it has these 5 different areas on mobility, self-care, usual activities, pain and discomfort, and anxiety and depression. So I'm just going to quickly run through how you get the numbers out of this. So once you've got this questionnaire, how do you actually get the quality of life score from it? So essentially you're asked to complete the questionnaire with how you feel today in each of these cases. So you could say, I have no problems in walking about, I have some problems washing or dressing myself, I have no problems with performing usual activities, and so on. It could be an extreme pain or discomfort and no anxiety or depression. You then have, again, I won't get into the details, but a tariff machine. So a calculator that you put these numbers into, and it then coughs out based on what your country's scoring looks like, a single quality of life score. So in this case, 0.160. Just to note, the one low level, so the extreme pain or discomfort, has a very significant effect on this score, making it much lower than otherwise. So then if you have these quality of life scores, you can then adjust them over time, as I mentioned. So if we've now got the QA bit of the QALY, we need to add the LY bit, so the life years, and bring them together to estimate the QALY. So imagine that we have a trial of 2 treatments, and we've collected EQ5D3L over 3 time points and generated our quality of life scores. So everybody in our intervention starts with a quality of life score of 1, both in the usual care and with the new intervention. Half a year later, the new intervention is still at a quality of life of 1, where usual care, the little plus, has dropped down to a score of 0.5. And then after 1 year, the new intervention is still doing really well. Everybody's at a perfect health quality of life score of 1, whereas usual care is down to 0.2. And then after 1.5 years, for simplicity, we just say that everybody's died. So essentially quality of life is 0 and life years stop accumulating. She can then join all the dots, and apologies if those lines aren't very clear, but it'll be a bit clearer in a second. And then estimate the areas under those lines to give you the quality adjusted life year. So that for the usual care, it's the brown areas. And for the new intervention, it's everything, it's the brown and the blue areas. So you can then estimate the quality of life years for the usual care, for the new intervention, and then work out the difference between the two of them. So the difference between those two areas. So finally, what do we do if the new treatment's better but more expensive? So this opportunity cost issue. We've covered the costs and we've covered the benefits so far. So this is the final piece of the puzzle. So we need to know how the health gain from the intervention compares to the health lost from what we would have had to stop doing elsewhere, because essentially you're having to pull money from elsewhere in the healthcare system to fund this new, more expensive treatment. So you can see it as 2 hurdles. So we've covered the first hurdle about whether it's better than the current treatment, so whether it generates more QALYs, but is the extra cost that it might imply worth it? Apologies for the typo on worth it. These are taken from an animation I did years ago, and so it's stuck forever on YouTube with this one small little typo. So how do we actually do that comparison? So first you need to work out how much it costs to gain 1 unit of health with this new intervention. So quite simply, the cost per 1 QALY, essentially. So this then gives you a ratio that compares the additional, so the incremental costs and the effect. And this is what an ISA is. It's an incremental cost effectiveness ratio. So just this cost per QALY gain. So you then compare this ISA to what you would have had to stop doing to afford it. The easiest way to sort of vision this in your head is to think about a bookcase. And I really like this idea. So it's this idea that you can line up all of the things that you spend your NHS spending on a bookcase, where the books are ranked by how beneficial they are to the patient. So the health of them is how tall the book is. So ideally, if you had a new intervention, you'd put it, say, somewhere in the middle, and it would push the book at the lowest beneficial book off the end. So the little one right on the far right. But of course, we don't really know the benefits of everything that we do in the healthcare service, and they can't easily be portioned off into these neat little packages. So instead, we have what's called a cost effectiveness threshold, which is an ISA cutoff below which taking money from other current services is worthwhile, and above it, it's not. Unsurprisingly, there's a huge amount of rabbit holes here about how do we value a QALY, how do we apply the thresholds, but the main values to take away from people, for people to take away, are the one that NICE uses, which is this £20,000 to £30,000 QALY, which often you'll see popping up in the media. But then also this Claxton estimate, which was an estimate to actually try and work out what the threshold was in the NHS. So hopefully you're now brimming with questions, whether they're confused questions or what next questions. So things like, what about other outcomes beyond health? Things that aren't included in the EQ5D? What happens when a person's at the end of their life and you can't really talk very well about the life year extension that you'd need to estimate a QALY? What about the impact on carers and loved ones, costs beyond the NHS and PSS budgets? If the effects aren't certain, health inequalities, estimating future effects, whether a QALY is worth the same for everyone. So whether there's this argument for fair innings, so that someone who's already lived a long and healthy life, are QALY benefits to them worth the same? So some of these will be dealt with later by my colleagues, and some are endlessly argued forwards and backwards in the literature, but none of them really have easy answers, but they're all areas that are being developed or have been developed. So really just a couple of takeaways from this that economic evaluation isn't about valuing health or life. It's about getting the most of each for what the NHS has to spend. The QALY and the EQ5D with it has a lot of limitations, but it is a powerful general approach. And the economic evaluations is to aid decisions, not necessarily to make them. And the fundamentals really are hopefully intuitive, even when the methods can be sort of as thick as pea soup. And I always think this image sort of sums it up very well, that we can't fund everything. That's just a fundamental truth of any setting. So that anything new that has to be funded by the NHS has to necessarily push something else out. So it's just making sure that we've considered the values of those two things and compared them. Thank you very much. I will stop sharing that.
Thanks, Seb. Yeah, really fantastic presentation. You've got some really positive comments in the chat as well, so big thanks for that. So good that you made Jane McDermott's head fall off, which is quite impressive. There's a couple of questions actually. One's gone into the Q&A and one in the chat. So Dawn's asked, I think Chris might have been answering it, but Dawn's asked, Chris, you might want to take it actually. As John said, I assume you can't define QALY or ISA without a study or studies that have a control group.
Okay, can I answer that verbally then? I mean, the process requires you to compare against something. So you do need to have this incremental comparison against a counterfactual treatment option, which may well be usual care. So that's absolutely 100% necessary. How you construct that comparison is a different question, I think. Ideally, we would have large RCTs, which would have all the relevant treatments in there, and we could put that together. But as I think we're going to see later on throughout this, this presentation, the presence of RCTs like this isn't always guaranteed. So we have to be pragmatic in the way that we construct these types of alternative measures. So ideally we would, in practice we can't always, and therefore we need to have some other way of constructing it, but we will always need to be able to compare it to something else in order to get these incremental QALYs.
Thanks, Chris. And yeah, there is a Q&A tab at the bottom. I always forget this, so people can put specific questions in the Q&A. I don't mind if they put them in the chat as well. I've got maybe a very quick one, Seb, and then we'll move straight on, actually, just conscious of time. Very quick answer. So John Silcox asked, also worth noting, generic quality of life measures, are they, he says that they may not be sensitive to change as a question. So sensitivity of change of the generic measures.
Yeah, and that's one of the sort of big criticisms of them, and potentially why the shift to the 5L was suggested, to try and make it a bit more sensitive. But there will always be specific issues around specific diseases that need that additional sensitivity. And I think later today we'll be talking about the sensitivity of different outcomes and when you would want to move away from one of these genetic measures.
Marvellous. Big thanks, Seb. There's another question, but we might take that forward to the panel discussion. Actually, that might be something to take forward. So moving straight on, I'll pass on to Rachel. So next we've got Rachel Meacock. Rachel's a senior lecturer in health economics at Manchester University. Rachel's going to talk to us on how economic evaluation has been adapted for service delivery and organisational change. So over to you, Rachel. Oh, you're on mute, Rachel, sorry.
Just trying to get rid of the top bar on Zoom so I can show you the right thing. That's not working. Worked so well for me earlier.
Yeah, that's all right.
Practice. Right, I'll just... Sorry. Display setting. Always does this to me, shows me a different thing when we've got started.
Is it that one you're looking at? Swap presented here on slides?
Yeah, I've plugged my monitor back to
yeah,
do it.
Yeah, we're there.
It won't let me click on it, of course. Right, one sec, sorry. Swap them. So now you should have the right view.
Yeah, we've got your title page in the right view.
But are you on presenter mode, or are you seeing the right? Are you seeing my perfect?
Yeah.
Great. So yeah, hi everyone. So my name is Rachel. I'm going to talk to you about how some of the methods that Seb had spoken about, the kind of core economic evaluation methods, have been adapted for situations that actually a lot of you, it might be really relevant for the stuff that you do in your ARCs. So evaluating interventions where it's kind of a change to the way that services are delivered and the way that they're organised. So just to recap on what Seb said, so economic evaluation provides us with a framework to assess the costs and the consequences of healthcare programmes. And it's all about informing decisions about what the best things that we can do with our scarce resources. It's about choices and it's about trade-offs. Just to say that you'll notice the language that I'm using is very much kind of health and healthcare. And that just reflects the facts that this is where the origins of the methods come from. So they do very much come from kind of an NHS perspective and evaluating interventions in healthcare settings where we are, the outcome that we're interested in is health. Clearly now we're moving much more to appreciating the importance of evaluations in other sectors. And I think particularly relevant for ageing and frailty is obviously going to be social care. Other people will pick up on that, but I'm going to kind of be sticking mainly to a health setting. So, you know, no evaluation is ever simple, but as Seb alluded to, talking about where the economic evaluation methods have kind of traditionally come from something you might have heard of called health technology assessment, or HTA. And so it wasn't exclusively, but the methods have kind of come from the evaluation of drugs. And as we've said, often in a kind of randomized controlled trial setting where we've got primary data collection. So we've gone out and we've collected data from the people receiving the treatment and the comparator group. And Seb covered the NICE reference case, which is an incredibly prescriptive thing. It's a very strict set of rules on exactly how you should do your evaluation. And as we look at services, we really have to move away from that kind of strict set of guidance and like recipe book. So changes to the way that we organize our services, the way we deliver them, the way we finance them, right up to the top to kind of health policies, and they're not covered by that NICE guidance. So they're not covered by that set of rules, and they don't undergo mandatory assessments for cost effectiveness. So if the NHS is going to fund a new drug, it has to go through that NICE process and show that it offers value for money. A new policy can just be introduced and it doesn't have to go through that assessment. And the same way that a hospital can also just introduce something that they want to do, they'll probably go through a business case, but they haven't had to do that strict assessment of cost effectiveness. But then, you know, often we'll get requests in our ARCs and will come to us and we'll be asked to evaluate this sort of thing. And it poses some additional methodological challenges when we move away from the kind of traditional NICE setup. So just to make sure that we're on the same page and you know what I'm talking about when I talk about a service intervention, for example, a great example I think of an economic evaluation of a service intervention was done by the team at UCL, and this was about centralising stroke services. So previously stroke services were provided by every hospital in the country, but there's quite a lot of evidence that showed that better outcomes for patients could be achieved if we basically had these specialised centres. So we really concentrated our expertise and we tried to send patients to these few hospitals that really had all of the cutting edge expertise. But that might involve sending them further, but we basically sent people to a few places rather than everywhere. And so obviously that's a big change in the way that those services are organised and provided, with lots of different things going on. You know, there's a long care pathway for stroke. And so that's kind of a really good example of what I'm talking about. And I think for ageing and frail patients, the kind of new thing, although some of you know it's not really new, but is virtual wards. So basically the notion that now, instead of providing care for patients in a typical physical hospital ward, there's a lot of moves in the NHS to provide virtual wards where people are actually in their own homes and they're remotely monitored by healthcare professionals. And again, that's a total reconfiguration of the services that are being provided. And so that's what I mean when I'm talking about service evaluations. So what makes them different? Why can't we just take those nice rules and kind of apply them? any of you have tried to do these sort of things will know that the real world is just really messy and it's really complicated. So a lot of the time, these service interventions, they're implemented at a much higher level. So they're implemented at the level of an organisation or a system. So they're not targeted at individuals. So it's not, very simple example, should we give patients a statin or not? That's a kind of very simple intervention where we just give it to the person and that's kind of it. Whereas this is kind of changing the entire way that the hospital provides services. And so with that, it can be a lot harder to identify the effect of the intervention and really say that it was because of what we changed. So, we changed something up here at the hospital level. Loads and loads of things happen to those patients. We try and look at their outcomes, and we're really trying to attribute the change in their outcomes and say it's definitely because what we changed in the service. And so it's kind of a more diluted between those two things. And the effectiveness of these interventions is so heavily dependent on other areas of the system, the context in which they are introduced and the human element. So a lot of the time we'll find that changes to service interventions can really work well in one setting. So for example, virtual wards, if that is just taking the group of patients that would have been in the physical hospital ward, it's caring for them in their homes when they may be less likely to, acquire a hospital infection. But the nurses don't have any extra workload. They're all just monitoring them from the hospital. Maybe it works great. If we've got patients in virtual ward, because we've got the hospital ward still full and we've got an extra load of patients in their homes, the ward team may not have the time to really monitor the patients at home. And so in that instance, virtual wards might not be great. So you'll see they can really depend on context, and we really need to try and figure out what is it about the intervention that works and maybe why hasn't it worked in some areas. And I suppose just to say that today, I'm not going to give you all the answers to kind of exactly how you could do one of these interventions, because, as Seb alluded to, it'd take a whole day. But the first step is to think about any of these challenges. If you're tasked to do one of these evaluations or think about one, first step is to think through these challenges and kind of how are they going to apply in your setting, and that'll help you think about how you could do your evaluation. I'll point you to loads, the slides are going to be shared, and I'll just point you to loads of kind of further reading that if you wanted to go and do these things, these could provide you with them, more guidance. Service interventions are also different because the decision context is really different. So whilst NICE make a decision about whether a product is value for money or not, NICE don't have to balance the books. So NICE don't need to find the millions of pounds to fund that new product themselves. They just say it's cost effective. It's kind of up to the NHS to then fund it. In a service evaluation, those resource constraints are really real. If I'm trying to persuade my local hospital to introduce my intervention, they're going to say, well, here's my staff team, what do you not want these people to do so that they can do this new thing? And so I think you might be facing very different and decisions that are much closer in your face. Service interventions also, and you really need to think about this, have indirect and unintended consequences which span the system. So because everything's so interlinked, you kind of change one thing here, it's going to have like knock-on effects for lots of other people. And so we often need to widen the scope of these evaluations to make sure that we assess the full impact of what's going on. As we've alluded to, these are very rarely tested through randomized controlled trials. So if we've got a trial, it's very easy for us to attribute through the randomization process that we know that any differences between our treatment and control groups are because of the intervention. That doesn't really happen in service interventions. They just get introduced. Quite often someone will come to you 2 years later and ask you to evaluate it. So you've really not been able to collect any data. And so Chris is going to do a great talk later on kind of how you deal with those challenges. So I won't really cover them, but just to say they're a huge challenge in this area. So how can we overcome these challenges, and what have people kind of done to do these evaluations? So as I alluded to, every intervention and every evaluation is different. And so there is no rule book yet. But yeah, think through these challenges. and think about how they apply to your specific situation. Some are going to be more of an issue for you than others. And I'll point you to some guidance. And then, yeah, Chris will cover the non-random introduction later. So I'm going to cover two main areas where I think we have made quite a bit of progress in the area. So the first one, and Seb talked about this, was kind of outcomes and how we can, when we often don't have primary data collection, so we haven't been able to give the EQ5D to people and look at how our intervention has affected that, how we can still assess the impact of service evaluations in this kind of common metric of a QALY, so that we can do those trade-offs between whether these interventions are worth the money. Just to say, you will probably want to look at other outcomes as well. So, you know, if you're evaluating your service intervention, you're probably still going to want to look at the outcome, the intended outcome. So, you know, if it was about quality improvement for patients with heart attacks, for instance, and it was targeting the amount of people who are given the correct drugs on arrival, you're probably still going to want to look at whether it achieved that aim, first of all. For these group of patients about kind of aging and frailty, you know, intermediate outcomes might be really relevant here. So things like pressure ulcers for these patients, you know, the number of falls, the cases of dehydration, these might also be really relevant. For hospital interventions, we often look at readmissions and length of stay, both because they are relevant outcomes for the system and for patients, but also because they're really easily available in the data. And so when we are relying on this secondary data, we often have to kind of, you know, do with what we've got. And so these are kind of easy to calculate with hospital data that we tend to have available to us. Information on mortality is also often available, and obviously such an important outcome. So we'll quite often look at that. But to do a full economic evaluation and be able to compare your intervention to other demands on healthcare resources, you do want to try and get your impacts in terms of the QALY if you can. Obviously, this is for NHS interventions where health is the kind of thing we're trying to maximise. And I think in the area, there's been three main developments of ways you could do this. So whilst there isn't really primary data collection of the EQ5D, there is one exception. And that's for patients with certain types of surgeries. So patients with hernia surgeries, varicose veins, and hip and knee replacements. The NHS actually did have this huge data collection exercise called PROMS. And so if you are looking at anything to do with these patient groups, there's actually EQ5D data from millions of these patients. And so if you were doing an evaluation in that area, that could be a great resource of primary data collection for you. Obviously, most of us are not going to be looking at those patient groups. And so there's two kind of indirect ways that we might want to go about getting our impacts in terms of QALYs. And so something that we developed was called a Dan Quayle tariff, which I think Dan Quayle was also some American vice president who couldn't spell potato or something. So maybe not the best name. But this is basically, if you've got an intervention that has targeted and what that has significantly impacted mortality, then basically we've kind of got this indirect way of saying, okay, well, if we saved this number of lives, we've averted this number of deaths, we can estimate the QALYs that would have been associated with that gain. So basically, kind of, we know the life expectancy of patients, and so if we've prevented those deaths, we can tag this tariff on, and it gives you an indirect estimate of how many QALYs gained. And that's been applied to COVID patients. So that's one option. Your other option is economic modelling. So Seb didn't really go into this, but in your kind of standard economic evaluations, you'll have trial, and the trial will do the short-term impacts on costs and benefits. And they'll quite often be supplemented with an economic model at the end, because we don't tend to track patients 10, 15 years into the future with trials. And so that economic modelling basically takes estimates from the literature and kind of combines them, and there's no reason why you can't do that again with a service evaluation. So you've kind of got your short-term evaluation using your administrative data, and then you can supplement that with estimates from the literature and do some modelling. So for example, if we have averted falls, there'll be some estimates in the literature about the kind of quality of life impact of a fall, and so you can use that. And yeah, these slides will be made available. So if you're interested in any of these methods, kind of further reading on how you could do that. And the bottom one, I think, is, yeah, a great example from the team at UCL about how they kind of did their service evaluation using administrative data and then did some economic modelling at the end to get a full economic evaluation out. The second area where, as I highlighted to you, is a real issue for service interventions, and I think hopefully we've made a bit of progress recently, is accounting for spillover effects. So as I alluded to earlier, spillover effects are basically any impacts on costs or outcomes other than those specifically targeted by the intervention. So you might know them as unintended consequences. So they can be positive, and that means that more patients have benefited from our intervention than was originally intended if kind of quality improvement spreads. So for example, if we had an intervention in the emergency department that was really about quality improvement for heart attack patients, but actually the healthcare professionals could kind of take some of that learning and maybe they've applied it to other patient groups who've come in, so patients with stroke, then if we didn't capture those wider benefits, we might not think our intervention had had enough effect to be cost effective, but actually we might, if we capture that full spread of quality improvement, then actually it might have been a worthwhile intervention. On the flip side, spillovers can be negative, so particularly if more effort is allocated to some patients at the expense of others. So with the same example, if we've got an intervention that's everyone's really focusing on patients who've come in with heart attacks and really improving the care for them, but if that means that other patients in the emergency department are left to wait longer because everyone's focusing on the heart attack patients, then that could have a negative effect on other patient groups. And again, we need to capture all of those effects to really know the full impact of service interventions. In economics speak, whether your spillover is positive or negative is going to depend on whether the tasks are complements or substitutes. Basically, that means whether the kind of the things that you're getting people to do kind of go together or where they're pulling them apart. And so, yeah, why are they important? So if you're going to do an evaluation, there's two reasons why you need to worry about spillovers. So first of all, in your evaluation design, so as I've alluded to, kind of you might need to widen the scope of your evaluation beyond the targeted outcomes and the targeted groups. Because if you don't get all of the impacts on the costs and the consequences, then you might end up either under or overestimating the true impact of the intervention, and so making an incorrect recommendation about whether it really was worth the money or not. And another thing that obviously is going to be really relevant to what Chris speaks to later is about carefully choosing an unaffected comparator group. So if we've got spillovers then onto a patient group, we can't use them as the control because it's going to bias our estimates. And so a wonderful colleague of mine has developed a framework that's come out recently that hopefully is really helpful just in terms of that thinking. So if you're planning your evaluation, you go through the steps and map out like, okay, well, what outcomes might be affected for who, or what level that spillover might occur. And so hopefully that's a really useful resource for planning and undertaking your evaluation to check that you're getting all of those impacts. So to conclude, service evaluation is really messy, it's really complicated, and there is no rule book. There's been quite a bit of development over recent years in how to evaluate healthcare service interventions in a manner that's comparable to traditional health technology assessment. Obviously, for us, evaluating costs and benefits of health and care services is going to be really important. And I think looking at social care, probably you face some additional challenges and require some further adaptations, but hopefully the developments made for kind of healthcare service evaluations provide a building block. And then some of the other presenters will talk to you later today about social care interventions and that wider perspective. And then, yeah, the slides will be available and there's some more general reading for you in there. But yeah, thank you very much.
Thanks, Rachel. That was really fantastic, really, really clear presentation covering some pretty complex areas. But yeah, they're really fantastic, actually. There's a couple of questions. It seems as though Chris might be picking one up in his talk, and the other one is a bit of a broader question, might be one Matt to take into the panel discussion later. So I think probably also in the interest of time, we might move straight on to Matt Fran. Rachel, that was really, really great. So moving on, next we've got Matt Franklin's Senior Research Fellow at the School of Health and Related Research at the University of Sheffield, and Matt's going to talk to us about economic evaluations to inform local commissioning decisions. So over to you, Matt.
I'm hoping this has worked. Can you see my screen?
Yep.
Yep, excellent. Well, thank you for having me today. And I'm going to be talking about economic evaluations to inform local commissioning decisions, challenges and opportunities. I was going to give a blurb about me, but I'll ignore that for the sake of time. So let's get straight into it. So why is local commissioning important to aid in research? Well, the fact of the matter is actually a large proportion of care commissioning budgets are at local levels, not national levels, with the main exception being drugs. So in reality, what we've got is these organisations like clinical commissioning groups, which are going to move into the integrated care systems. And these are NHS commissioners, which commission the majority of NHS services. Now, they did hold around about 2/3 of the NHS budget. So they're a big play in terms of commissioning services. But also there's commissioners of kind of non-NHS services. So local authorities like city councils, publicly fund social care and some public health services. Now, an ageing population requires cost-effective care across these sectors and regions. And so the evidence that we develop needs to appeal to these local commissioners. When moving research into practice, that means that we need to produce appropriate evidence to inform their commissioning processes. But if evidence is not geared to local context and evidence needs, it's quite possible then that services or interventions which we suggest are cost effective aren't actually commissioned. And this can be due to disconnects in producing inappropriate evidence or even misunderstanding evidence. And this can act as a wall. So we can be ended up talking two languages, and we could be producing evidence that actually can't make it into practice. So we've already talked about the kind of standard conventional economic evaluation. The most common one is obviously what NIHR recommends, which is associated with health technology appraisal processes. There's this kind of cost per quality framework. We base the quality adjustment on the EQ5D. We produce incremental cost effectiveness ratios. There's other things like cost effectiveness planes and CACs. And we tend to compare this to a cost of excess threshold. Now, these methods aren't wrong per se. They have been developed over decades, and we're still developing them with huge focus. But there is an issue that local commissioners don't actually base their commissioning decisions on the aforementioned evidence. So there's a real disconnect between research evidence and actual practical use of this evidence for commissioning. And there's kind of 7 perceived elements of disconnect. Now, there's a fair few papers out there which are worth reading where people that develop economic evaluations, like health economists, have actually talked to local decision makers about their evidence needs and the economic evaluation framework. A lot of what I talk about today comes from an ARC funded project done by people in York like Seb, Laura and Gerry, all of whom are talking today. But there's also some other work done by other people like Emma Frew over in Birmingham. And the 2 papers I've particularly reflected at look not only at the CCG NHS perspective, but also what's needed for local authorities. So this kind of cross-sector perspective. And if you look over these papers, there's a fair few things which are common and commonly come up across sectors, but there's basically 7 elements of disconnect, which I'm going to get into today, where the conventional economic evaluation differs from actual local decision maker reality. And this includes the use of cost-effective threshold, implications of decision uncertainty and budgetary excess, the valuation of future costs and outcomes, and then the scope of included costs or included outcomes, and then the transparent reporting of costs and effects for different sectors and subgroups. Now, these are rabbit holes, as I said before. So what I want to do is give an overview of these 7 challenges, but basically lean into this idea that there's opportunities, and actually health economists already have a lot of tools at our disposal to try and deal with these elements of disconnect. So let's get into it in terms of the cost effectiveness threshold. The cost effectiveness threshold has been introduced, and it's really useful for a binary decision. So the idea that something is cost effective or not. So for example, if we're paying £40,000 for something and we get 2 QALYs and our cost effective threshold is £20,000 per QALY, this is cost effective at this point. And we can kind of move across this line. So if we're paying 20,000 for one quality, this is considered cost effective. If we're paying 60,000 for 3 qualities, it's still cost effective if we're willing to pay £20,000 per quality. If we end up with an intervention actually that can produce 2 qualities for £20,000, this is below the line, so obviously it is cost effective. But if we end up producing 2 qualities at £60,000, this is above the line, and their spell wouldn't be cost effective. So it's really useful to try and guide these ideas around cost effectiveness or not. And it's important to realize that actually there are implications of having too high a cost effectiveness threshold. So if we're willing to allocate too much because we put a larger value on per quality gained, this can lead to opportunity costs, because if we put that value, extra value on the qualities, wherever we spend that money can't be spent on anything elsewhere. So we said, right, we're going to pay £30,000 per quality, and we start investing in stuff that's £30,000 per quality. It might mean that actually new future interventions, which are £10,000 per quality, we can't actually fund in the future. And I'll get into this idea of disinvestment and displacement under my second challenge. But the other thing is that using a national cost effectiveness threshold can be misleading and isn't currently linked to a very important concept of affordability. So there is this idea of a paradox that you can have something that's cost effective, but it's unaffordable. So for example, if we said that, right, this intervention here is, it costs 40,000 and we get 2 qualities, this is cost effective, but actually when we put this to a population of 100,000, so 100,000 times 40,000, actually this becomes unaffordable. So it goes completely outside our potential budget. So we need to account for affordabilities. And the fact of the matter is, cost effectiveness thresholds are likely to vary at local levels when we start thinking about linking outcomes to actual care spending and the displacement that causes. So kind of supply side cost effectiveness threshold, which is related to that Claxton threshold, which Seb presented earlier. Challenge 2, in terms of exceeding budgets. At the national level, there is some flexibility with moving between budgets and even moving budgets over time. At the local level, however, this is quite different. There's very little flexibility. There are implications if you overspend. And this idea of a new care technology, if you bring something new in, the budget tends to already be spoken for. So if you bring something in new, you need to get rid of something else. And this requires disinvestment. And disinvestment is a complex concept, particularly for commissioners to tackle with. Because people like it when you bring in new stuff, they don't really like it when you start taking away stuff. So affordability is a major concern here, but budgets are very complex. But there are ways that you can start to think about how can we take into account budgets within existing frameworks. So for example, you could start to think about, alongside your conventional economic evaluation, should I do a budget impact analysis? So you can see on the right here, I've given a very brief overview of what budget impact analysis might be when you start to look at the population, target population resources and cost of illness of what the current environment is, compare this to the new environments, and any difference would be the budget impact. There's also a method which isn't really used that much anymore, but if you talk to local decision makers, they're familiar with it, program budgeting and marginal analysis. It is a method which focuses specifically on budgets, but it's actually difficult to utilize, and it's at times it's difficult to actually identify the budget which is going to be spent. But there's new work around how can we actually account for affordability within the cost effectiveness threshold. This is quite complex, but it is an area which is being focused on at the moment. So when we're using the cost effectiveness threshold, is there a way to better account for affordability within that? In terms of challenge 3, the valuation of future costs and benefits, essentially NICE suggests that we should have a lifetime perspective with costs and outcomes discounted at 3.5% per year. So we start to value outcomes and costs in the future less and less. But this discount rate can depend on several factors which differ at the local level relative to the national level. And this includes opportunity costs of expenditure today, time preference, risk adversity, consumption growth, tradability of money and health. All this differs at a local relative to the national level. However, the actual direction and change in discount rate is difficult to suggest because the availability of investment options may reduce the rate, whereas the short-term nature of budget cycles may actually increase the rate. So although we're saying 3.5% might not be appropriate to the local level, the exact way it should move, we're not 100% sure, but it could be explored. Another challenge is distinctly the scope of costs. So as already mentioned before, NICE kind of suggests that we should focus on NHS and PSSS costs, and these are considered relevant. Unfortunately, this means that costs fall on public health budgets, patients or the carers, like non-out-of-pocket payments, aren't included in these approaches. At a local level, this approach kind of works to a certain degree for CCGs and ICSs who are focused on the NHS and the healthcare sector. It doesn't really work for other sectors, and this can be a problem if you're trying to deal with cross-sectoral economic evaluations. It's also possible for upfront costs to fall on one budget sector. So the LAs could invest in some kind of community-based service, some kind of social care service, and this will reduce admissions to hospital, but then the benefits are seen in trusts and on the NHS. Although the current healthcare bill promotes joint working between LAs and CCGs and kind of using joint budgets, it's still a bit of a concern and how to negotiate this kind of sharing of budgets and responsibilities, but also the benefits and savings later on. And I get into this more to do with Challenge 6. But also if we're going to include the whole range of costs across sectors, so NHS costs, social care costs, costs on care homes, education, transport, so on and so forth, you kind of need to know what resource use is happening there so you can apply unit costs to it. Unfortunately, non-healthcare routine data, in terms of routine data in this area, has complexities. For example, there's limited metadata. Metadata is data about data. So if I want to know what data is being collected to do with social care, actually, I can't go online and find that like you can with the NHS with data dictionaries. It's a lot more complicated to understand. And Chris will actually be discussing routine data considerations, at least for economic analysis, later on. And then a common thing that comes out is also the scope of outcomes. As we've already said before, the kind of recommended measure is the EQ5D, and the EQ5D works on the QA bit in the quality estimation. It's important to note that NICE is interested in impact on carer health related to quality of life. But there's a whole range of outcomes and even outcome measures which could be used. There's a wide variety of health-related and non-health measures. So you can start to focus on aspects like capability, well-being, subjective life satisfaction, and so on and so forth. We see a broad range of outcomes being interest, at least in terms of monitoring services. So with social care, we have the adult social care outcomes framework. But these outcomes tend to be used for monitoring, not for commissioning care services. That is, it's not directly linked to achieving to payment systems. So if you achieve an outcome, that's good for monitoring. But in terms of commissioning a service on that basis, there is no linkage there. And outcomes-based commissioning relative to commissioning on the basis of purchasing services in units consumed isn't really the norm. And in terms of this kind of scope of outcomes, Clara will discuss considerations related to measuring wider benefit later on. In terms of Challenge 6, costs and effects for different sectors, we commonly in economic evaluation report an ISA, and an ISA looks at incremental crossover incremental outcomes, but everything's kind of bundled together. So when you show an ISA, a single figure is useful to determine cost effective. It doesn't really tell you where these costs and effects are really falling. And obviously we often focus on a single outcome, which is the quality. And within these costs and effects, there tends to be limited non-health and non-healthcare aspects included, as I've described under challenges 4 and 5. But there are existing frameworks to try and deal with this. So for example, cost consequence analysis is a method, basically, it's an economic evaluation method, but it's based on disaggregation. So you disaggregate the costs, you disaggregate the effects, and you show all of them in a disaggregated fashion to your decision maker. The problem there is that decision makers can pick and choose which outcomes and costs they focus on, so that can be a bit of a problem because they don't always carry equal weight in terms of what you prefer to prioritize. An alternative method is multi-criteria decision analysis. The key thing about MCDA is that it involves stakeholder engagement and deliberation to actually inform weighting and trading off different outcomes, but also criterion. So what do you actually want to achieve? What's your maximum, for example? And there's been even newer methods to start thinking about, all right, how do we show the costs and effects in different sectors, like in health, other forms of consumption, on the criminal justice system. And this has been called an extended impact inventories framework. It kind of works like a cross-sector CCA where you're kind of looking at disaggregation, but you're focusing more on the different sectors where outcomes and costs will fall. In terms of challenge 7, cost and effect for different subgroups, this really stems into this idea that within health economics, economic evaluation, general policy making and commissioning, we're really trying to understand and tackle inequalities, particularly health inequalities at the moment. And we can actually end up with this kind of equity, efficiency, impact plane like what I show on the right, where it is possible to have a cost-effective outcome which can improve equity, but it's just as possible to have a cost-effective outcome which actually harms equity. On the other hand, we could end up with a situation where we can improve equity, but it's cost ineffective. So we can end up within these different situations, but there have been methods which have been designed to try and deal with this. And there's generally 2 approaches: impact and weighting. Impact is the more simple. It's basically you produce the cost effectiveness analysis, stratify the subgroups of interest, and then you report the respective costs and health outcomes for each stratified group, whatever that group might be, alongside the headline cost effectiveness summaries for the full population. Now, the more advanced method of this is the weighting approach, which is basically the same as the impact approach, but you have quality impact weightings by subgroup. And this is the basis of something which you might have heard of called distributional cost effectiveness analysis. DCEA basically allows a distribution of weights, so society's inequality aversion can be directly compared against total population quality gains willing to forego to reduce, minimize inequality. So it allows for this trading off between cost effectiveness and inequality. But Laura will discuss more about equity considerations later. So in summary, despite the 7 challenges outlined, there are actually methods and work ongoing to tackle each of these challenges, but it is often actually done at a national rather than a local level. So we do need to start thinking about the local level, given the budgets and commission that sits there. Across the 7 challenges, in terms of cost effectiveness thresholds, there's been work to do evidence-based cost effectiveness threshold estimations, but these have not been formally adopted. For example, NICE still uses £20,000 to £30,000 per quali, not that £13,000 per quali which Claxton calculated. I think it's even lower than that now. In terms of budgets, we do need to start thinking about accounting for affordability alongside the use of ISAs and CETs. In terms of future value, exploration of alternative discount rates would be useful. In terms of costs, we really need to start thinking about investing in metadata and administrative care record systems so we can get this routine data, which will then inform the analysis, which Chris will talk about later. There's been outcomes, so developing outcomes which actually work across sectors, so capture health and public health and other wellbeing aspects, such as the AQ health wellbeing measure, which Clara will talk about later. And in terms of sectors, there's simple ways of presenting results in a disaggregated fashion, and we can learn from methods associated with CCA, MCDA, and extended impact inventory. In terms of subgroups, there needs to be further development and use of DCEA in particular. This is really interesting method which we should look at. So there's a whole range of challenges and opportunities relevant for all areas of research and commissioning, but particularly commissioning of cross-sector health and non-health and longer-term care solutions are particularly pertinent to ageing, mental health and frail populations. So thank you very much.
Thanks, Matt. That's really, really helpful. I mean, I think that's where a lot of researchers struggle, actually, that sort of making that, well, bridging that gap between research, trial-based research and local commissioning decisions, and setting out those 7 challenges is a really helpful way to understand it better. We've probably got time for one quick question, actually. If I can find it. Oh yeah, here we go. So yeah, it's from Lisa Cummins. So asking specifically about using socio-technical allocation of resources to inform decisions at ICS level, e.g. across a pathway for a given condition. Well, any brief thoughts on that, Matt?
I know a lot of methods and a lot of approaches. I do not know Star.
Okay. Well, if anyone else in the panel does, then that might be something they could pick up. Laura, go on, Laura. Yeah.
I think it's equivalent to program budgeting and margin analysis. Matt, is my understanding. If that helps.
Oh, Matt Sutton's put a link in, actually.
Well, if it's similar to program budgeting and marginal analysis, it's been kicking around in CCGs and LAs for a while, and they did used to teach people on it. My recent conversations, because we've been talking about PBMA quite a lot, is actually it's not used and it's a bit outdated, and the consideration that you can actually at any given time point really know what your budget is a problem with that approach. We've been looking at it, but if ICS has restarted or at least renamed it, it would have to have changed a little bit for it to be used, because my conversations is that PBMA isn't being used, but there are principles alongside it, like really focusing on what your actual budget is, which does have an advantage. So
thanks, Matt, and hopefully that's helpful. Lisa. Should we move on to Clara? And again, helpful for Matt to signpost to the other talks that are going to be covering some of these areas. So next up, it's Clara Mukuria. So Clara is a senior research fellow at the School for Health and Related Research at Sheffield, and Clara is going to be talking to us on considering and measuring wider intervention benefits relevant for ageing. So looking forward to it, Clara, and over to you.
Thanks, Andy. Thanks. So as Andy said, I'm going to be talking about measuring outcomes, and some of these things have already come up in the previous sessions. Both Seb, Rachel, and Matt have all identified issues around benefits, but I'm focusing primarily on aging, just to think about what's special about aging. So just a quick recap, some of the questions that were thrown out by previous presenters. In economic evaluation, we are thinking about outcomes. We want to measure not just costs, but the benefits. And there's a question about which outcomes, and can we just measure a QALY? What if someone is at the end of their life? Therefore, QALYs by definition, they're improvements in quality of life, improvements in length of life, those will be restricted. Can we use QALYs? If not, what else can we use? And then what if the EQ5D doesn't cover what you're interested in? So particularly in aging, there might be things that you think those 5 dimensions don't cover. And then the other outcomes that are being collected out there, can we use them in economic evaluation? And then there's this other consideration around, what if the outcomes, not just a cost, fall on other people, not just those who are directly receiving the intervention. So in this case, for example, informal carers. So my first thought is what's special about aging? Is there anything different about people who are older? One of the things that we might think about as well, actually, for chronic conditions, they're likely to be deteriorating, and that might be just a gradual deterioration. It can be really rapid. And the methods that we are using, if we're just focusing on health outcomes, and we are saying, well, maybe there will be something there that will be a bit limited by just using a single measure, or just focusing on just health, essentially. They may have multiple conditions, and that might actually have an impact on them, on their not just health as we can observe it, but those underlying physiological functioning that means that they are frail. So when they get ill, something simple like here we have a figure showing someone who is not frail and someone who's frail. So the non-frail person is in green. They get an infection, urinary infection. The person who's frail will it'll have a bigger impact on them, and it'll take longer to recover, and it might have other consequences, not just on the direct impact on because of the UTI, but it might then impact on other things. They might become more immobile, they might not go out, and that then has other impacts. So there's kind of multiple impacts on this group that we might want to consider. And then end of life is particularly specific. As I said, you're at the end of your life, you're not unlikely to get many health benefits from an intervention. Palliative care might be maybe reducing pain, but generally speaking, you're at the end of things. There's not much we can do. And if you use something like the QALY to assess interventions in that a sector, then we might discriminate against it. So is equality really appropriate? So, and in this case, there's also things that there'll be more than one intervention, and the interventions might be health and non-health interventions. So we might have community support, for example, as something that is being delivered, and that's not necessarily coming from the NHS. And we're thinking, should we measure health in that context? So this sort of kind of summarizes some of the issues. So this is, health might be poor or even deteriorate. If we're just measuring that, will we be able to capture change? The EQ5D, which is recommended by NICE, but it may not reflect everything that we're interested in. For example, we may be interested in actually minimizing frailty, and EQ5D may not be able to reflect that. We might be interested in other outcomes for older people, for example, maintaining independence, which is something that in older people might be really important. There may be really short improvements in quality of life. So it might be the last month of life is that very, very short improvements in quality of life, and interventions may target non-health areas. And then there's this spillover, so consequences that fall on others who are not directly impacted by the intervention, such as family and friends who are looking after the individuals. And this may be both on their health and well-being. So we want to be thinking about these. How do we ensure that we measure the correct outcomes? I think it was alluded in earlier sessions that if we don't measure the appropriate outcomes, that we might make decisions that are inappropriate because we are focusing, we've not covered everything, or we are not focusing on the inappropriate end of outcomes. And what we want to inform decisions well by measuring the appropriate outcomes. So what can we do? I think it's already been mentioned in the chat that we can use, if we think EQ5D, for example, is a problem because it doesn't cover the relevant issues or outcomes that we're interested in, we are still thinking here about health, then we can use other measures. So the SF36 is a longer measure. It's got 36 questions, covers different domains of health, and that would allow us to capture some of the things that we think maybe the EQ5D is not able to capture. But both SF36 and EQ5D are missing some dimensions. For example, sensory dimensions, which might be relevant in an aging population, so things like vision and hearing. And so there are other measures like the Health Utilities Index, which cover specifically vision and hearing, and specifically the Health Utilities Index also includes, sort of incorporates the use of aids. So you can, as part of the questions, the setup includes aids, which might be useful. We could use non-quality measures. Matt mentioned that there are many patient-reported outcome measures out there that we can use. So some of them might be, say, for example, dementia specific or palliative care symptom severity measures. If we are thinking actually EQ5D or SF36 are still too generic, they're not condition specific enough. There is a challenge around if we want to use a quality framework, but we don't always have to use a quality framework. We can just run a cost effectiveness analysis where our outcome is a patient reported outcome measure. The problem will be the link to a threshold or an appropriate threshold, but we can still run a cost effectiveness analysis. And of course, we could use indicators, for example, hospital admissions prevented for palliative care. If we're thinking actually the other outcomes that are of interest, or the sector is very different, we are looking at providing support, someone coming in, then we could use measures that are designed for those sectors. So the Adult Social Care Outcomes Toolkit is a measure that's designed specifically to assess social care related outcomes, and it covers dimensions that are really specific to social care. Unfortunately, it doesn't have any health questions. So if you want to know about the health of the individuals, you'd have to ask them an additional question, that is a set of questionnaires. But it also has utilities in the same way that EQ5D does. So you can, in theory, run an economic evaluation and just look at ASCOT related, social care related utilities. The informal carers, as Matt said, there's NICE is interested in measuring the health of informal carers, and EQ5D has been used to assess the impact of caring and interventions that are delivered, directed at patients, but I guess you could also use it if the intervention is really targeting informal carers, like respite care, for example. It's going to be focused really just on their health, and a recent review indicated that it was the most commonly measured used. EQ5D, because it's been used, some of that Seb talked about stickiness of measure of issues in economic evaluation or in health economics. And EQ5D is one of those sticky things. So it's beneficial that you're using the same measure, but just because it's available and can be used doesn't mean that it's always appropriate. It's still the most commonly used measure, both in health and in other populations like informal care. Then you could look at carer-specific outcomes. If you're thinking, well, there's this other group that's being impacted by the intervention, you can ask carers around there about their caring experience. So there's an ASCOT for carers developed by the same group that focuses on specific aspects around caring, but you can also look at problems associated with caring, so care-related quality of life, where the issues that are focused on are problems with physical and mental health caused by caring. All these options require, especially where you have two sectors or you're looking at different groups, patients and informal carers, require you to use different measures, apart from if you just want to use EQ5D in both patients and informal carers. Whereas actually what would be ideal if you're thinking about assessing outcomes in a group of people for whom a single intervention is delivered, but you want to see the outcomes and spillovers, then a single measure would be more beneficial. And a team here in Sheffield, led by John Brazier, has developed a new measure called the EQ Health and Wellbeing. And there's a short version that can generate QALYs, and which covers a few additional dimensions that may be relevant in patients, but also in informal carers, such as things like exhaustion or loneliness, cognition, and control. So this are found to be important. But there is a longer measure that is kind of similar to the SF36, but can't be scored with QALYs. But that covers a whole range of issues that were identified as being important in patients, social care users, and informal carers. Now, there's also, just moving away from what measure should we use, some kind of practical considerations when thinking about like the aging population. So one of them is administration of questionnaires. So if you are thinking of collecting information in an elderly population, then there may be a burden of completing many questions if you want to ask if you need to use more than one questionnaire. And typically, we are not just asking one set of questions. Even where we are using EQ5D as the final measure in our economic evaluation, we've usually had to ask additional questions because if it's a sort of trial setting, the primary outcome is unlikely to be EQ5D. The primary outcome is likely to be a condition-specific patient-reported outcome measure or some other indicator of where we think the changes will occur. So although we might ask about EQ5D, we might want to ask, other additional questionnaires. And that, if you're older or you're struggling to see, you're struggling to answer questions, you may require an interviewer, and that might take time and money. And apart from just burden, it might be that the individuals themselves can't answer the questions that you want them to answer. So in a dementia population, later stage dementia, they may not be able to answer the questions for themselves. And in that case, then you have to ask who will answer the questions. So you might use a proxy to answer the questions. And there are, for example, EQ5D, there are proxy versions of EQ5D. And then we have this question, how well can proxies answer questions on behalf of the individual? Proxies might have different priorities or focus on different things. So if you're thinking about an informal carer where, say a partner of someone who is has dementia, what they focus on might be very different from if you could ask the person, what are you thinking, how you're feeling? They might be very different. So where we are getting proxies to answer, there's a question of what can we really get them to answer? Some of the dementia specific sort of questionnaires that have a proxy version and self-complete, so you get both completing, are very different questions to reflect that proxies can answer very different questions to the individuals. And then there's a question, how do you combine, which is the actual outcome, the proxies response, the self response, and how do you use that where you've got some people answering with proxy and some people not. So then finally, you might think about a context. So you might think, well, in some contexts, actually asking questions might not be appropriate. So for example, palliative care at the end of life may not be appropriate to be asking individuals, or they may just not be able to do it. And even if you want to ask what a common approach is to ask, again, some kind of proxy, but again, the appropriateness of it, whether they'll be able to engage at that point or at some point later on is a question that we have to take into account. In the case of informal carers, we might think that there may be more than one informal carer. So, several adult children taking turns to look after a parent. Sometimes you might ask for a primary carer, but maybe there isn't such a thing as a primary carer. Or the informal carer themselves might provide care to more than one person. So caring for elderly parents as an adult, you might be caring for two different people. There's challenge in recruiting informal carers and following them up and linking their outcomes to the interventions. If the intervention itself is not directed at the informal carer, that might be challenging to do. And then there's a difficulty of separating outcomes that are related to the carer themselves, as in their own health, that's nothing to do with caring, and actually something that is a direct impact of caring or an intervention, especially in observational studies where we don't have a before and after. That might be difficult. So one potential solution to the challenge of collecting data in this age or this group is to use a cohort study. And Andy and his team have this wonderful resource, which is a community aging research, which is a cohort study of people aged over 75 that has nationwide recruitment and collects a whole host of health, social, and economic data. It includes the SF36 as one of its questionnaires, started in 2014, and currently has over 1,300 participants, which is really great. And it's a really rich resource with available. You can use the data to answer research questions, but it's also possible to recruit patients or participants for trials from within the cohort. So you have the advantage that you know who they are, they've signed up to take up part in research, you have questions about them beforehand, so maybe you don't need to ask them as many questions at the start, and you have linked data to the NHS, which is part of the cohort. So it's a really useful resource. The link is there, it's something that's worth looking into. But it's a solution of targeting frail or more older people. So they're not all going to be frail, but it's a solution of targeting this group. So there's still some outstanding considerations. If we do have different outcomes, how do we aggregate them for decision making? Matt alluded to just looking at different outcomes in disaggregated ways, but as a decision maker, you might think, but which is the most important? What should I focus on? Or actually everything is important. I want to know overall whether this intervention is worth doing. So that's a challenge. And then there's a question about the value of outcomes. So if do we value the outcomes for informal carers in the same way that we value outcomes for patients? And if not, why not? And how would we do that? How would we justify valuing informal carers outcomes differently? And are we assessing the total benefit? So where we have a single outcome measure and we are able to measure everything, for example, if we use EQ5D for both informal carers and patients, what if the informal carers are better off but the patients are worse off? And then this question has come up before: how do we apportion outcomes to different sectors and budgets? So a number of issues raised there, but things that have come up before. Hopefully this has raised things to think about when collecting data in an aging population, and I'll stop there because of time.
Thank you, Clara. Really helpful overview and discussion of, well, obviously the measures and some of the alternative measures. There's been a fair bit in the chat actually, and maybe Chris Todd's question, which sort of links to a point that Tracy made actually as we were talking. So Chris says, and I think most people would agree with this, EQ5D is often the go-to measure as it's perceived as being well validated and sure, and as Laura points out, NICE mandated really. You mentioned these issues around burden, proxy response, but I think Chris was wondering how well validated are the other measures that you've been talking about?
And that's a great question. A number of the measures will have great validity. They're very well validated. For example, SF36 that you guys use on the Care 75 cohort, that's a very well validated measure, has been used for many years, is sort of internationally used. So that's a very well validated measure. The ASCOT, for example, is a well-tested measure. It's actually used in the adult social care outcomes framework as part of, it's one of the measures they just routinely collect as to routinely monitor. So it's a well-accepted, well-validated measure. Some other measures like the new measure, the EQHWB, obviously that's a new measure, so it doesn't have validity yet. That's something that takes time. And I think that that's the thing about EQ5D. It's being used, and now because it's been used and recommended, it's been used, and therefore you have validity data on it. And this is the challenge of trying to move from something to something else where you think something else might be better. So the health measures probably have more validity evidence than the other outcome measures, but in each they will have been tested and developed for the particular populations. Yeah, so I think that's a key problem of newer measures. If you want to address the problem, then you probably need another 10 years maybe before you have say for sure a new measure is valid for every population.
Yeah, absolutely. I mean, that's a bit of the tension. And again, we might, if we have time, come back to it in the chat, that tension between NICE mandated EQ5D versus some of the other measures which are perhaps more relevant for the populations that we work with, but that NICE wouldn't necessarily support. So that may be something we can come back to. But yeah, no, thanks again, Clara. Really fantastic presentation. And I think that brings us to the end of our the first part of our meeting today. So it's 11:35. I think we're due to start again at 11:45. So we've got 10 minutes for a coffee, short break. And I'm sure you'll be pleased to know that after we come back, it's Matt Sutton who'll be chairing. So really looking forward to the next session as well, Matt, and looks really great. So we'll see you all again in 10 minutes. So yeah, big thanks again to the speakers and to everybody for their great questions and engagement.
Thanks, Andy. See you all at 1:45. Thanks.
As you've heard about in previous presentations, does conflict with the principles that are set out by the WHO. So economic valuation seeks to maximise health for a given budget. And so when it chooses between competing interventions, the focus is very much on average population health. And also when moving beyond health, it may indeed choose to maximise other outcomes of interest, such as, say, well-being or educational attainment. And of course, this makes the implicit equity judgment that additional outcomes, including health, are valued the same regardless of who accrues those outcomes. And in many decision-making processes, including the National Institute for Health and Care Excellence, NICE, there's little information available that's presented on the distribution of costs and benefits across a population. It's not clear who would benefit if a decision was made to implement what's regarded as a cost-effective intervention. And there's no formal process by the likes of NICE to reflect equity in its decision making. Decision makers, however, may benefit from reflecting equity into their processes, and this can be because of a number of different factors. So it may be that uptake, adherence, efficacy of interventions may be better in socially advantaged groups. And it's often the case that although we target a lot of resources at the most deprived groups, often the opportunity costs of interventions and health are most borne by disadvantaged groups. And it can be that in some instances, interventions can actually increase health inequalities. So that we would regard that as intervention generated inequality. And it's also the case that a policy that would result in the most equal distribution may not provide the greatest increase in overall health. So we potentially have this kind of difference, this trade-off that needs to be reflected. And it's sometimes the case that interventions are more costly to deliver to socially disadvantaged. Okay. And because of this potential conflict around who gains, who bears the costs, we need to consider these trade-offs. Whereby we may forego population health to reduce health inequalities or potentially exacerbate health inequalities through interventions that improve overall health. And we need to be aware of that kind of potential conflict. So when I talk about measuring inequalities, what types of variables am I kind of referring to here? So these would include things that are related to kind of socio-demographics, they're related to economic status, demography, and also geography as well. And I've got some examples here which include things such as social deprivation or ethnicity. And these are measures that are kind of commonly used as indicators in terms of distribution of health and outcomes. And there are different measures available to health economists and healthcare planners that enable us to gauge equity or inequality in health. There are different measures of variation or spread, and these include things that are quite simple measures that are quite easily interpreted, such as life expectancy and life expectancy gap within a population. Regression-based measures, which just go beyond that in terms of looking at the slope. And more advanced kind of entropy type measures that have been developed that have moved on from things like the Gini coefficient. And there are also measures that focus on the impact of a given change in the distribution of health. So for example, relative inequity. And this is the ratio between two groups. So it may be between those that would be regarded as in areas of which they were socially deprived and less deprived groups. And then also absolute inequality measures. So that would just be the absolute gap between those two groups. And these different indicators are obviously correlated because they're in essence trying to measure the same thing and also using bits of information that are also the same as well. But the conclusions about the magnitude of inequality can differ. And also the direction could entirely differ as well. So what do these different measures of inequality mean for aging research specifically? So the first thing to know that I mentioned at the beginning is that older people have tended to be quite neglected in research on inequalities, and particularly thinking about inequalities that are generated as a result of delivering an intervention that's considered to be cost effective in terms of the average population benefits. There's been lots of work on inequalities that has focused on early years. However, of course, these inequalities in younger years and adulthood can have implication for older age. And inequalities in income in particular can also persist for pensionable age individuals. So the measures that I've mentioned on the previous slide do have implications for prioritisation and spending of healthcare budgets. So an approach such as the kind of fair innings approach, which takes the view that there's some kind of span of life years that we consider as society to be reasonable, that people should attain that, will inevitably attach a higher weight to younger individuals. And then something like an absolute measure may well favour younger individuals, again, because individuals at an older age would be considered to have impaired their stock of health. And whereas relative measures may favour older individuals. So in the new NICE guidance for appraisal, which some of you may be aware of, both absolute and relative methods are going to be used, which potentially may produce a more kind of even spread compared to the previous criteria that's been used to think about allocation by NICE. And I've got an example of what that means here. So we can see on these two figures, which compare the number of appraisal topics by NICE that would have received the end of life modifier, which is the old weighting method, and then the severity weighting, which is the new method that's proposed by NICE. And we can see that many more topics received the end of life criteria and thus were likely to be funded even if high intervention costs prevailed. So they were more likely to fund those topics for groups that are age 60 plus. And so the new weighting is more equitable. Okay, so we get a better spread, but it may mean that there's less approval of topics that are targeted towards older groups. So that potentially will have an implication going forward. Although there are a few issues to work out with NICE around how they implement this severity weighting, this is one potential consequence. So next I'm going to give a quick overview of a technique that's been mentioned, I think, in Matt's talk, which is used to bring together cost effectiveness analysis with measurements of inequality, and it does so using a single framework. And this technique is called distributional cost effectiveness analysis, or DCEA as we call it. And it provides a distributional breakdown of who gains most and who bears the largest burdens in terms of opportunity cost when we conduct a cost effectiveness analysis. And this can be used then to employ equity weighting to explore that trade-off between efficiency and equity. And in essence, it looks at the total costs and benefits, or perhaps it converts those benefits into a kind of monetary unit using something like incremental net benefits. And it looks at those as a distribution of benefits and costs, reflecting different relevant characteristics, such as socioeconomic deprivation, for which there's data to distinguish those groups of individuals that's pulled through an economic model. So these are the steps to conduct a distributional cost effectiveness analysis. So we first need to estimate that baseline health distribution, that distribution of health. And then we model changes in this distribution due to different competing interventions. And I won't go through the detail there, but we then use this estimated distribution to quantify the change, so the baseline compared to the change in total population health, okay, and costs as well. And we look at unfair health inequalities due to each intervention. We can then go on to rank those interventions based on, as previously been described, kind of specific criteria. So which ones, represent a cost-effective use of resources, and then go on from that to think about any trade-offs between improving population health and reducing unfair health inequalities. So this is what it looks like kind of in practice in terms of the steps. And as I said, I struggled to find an example that was related to ageing research to kind of illustrate this. So apologies that this is a rather more kind of generic example. So this is an example of what would be generated from distributional cost effectiveness analysis. So I've specifically kind of pulled out the QALY results here. So we can see here who gains additional QALYs according to subgroups that have been specified by sex and IMD. And then this information on distribution of benefits and then also opportunity costs, so we do this on the cost side as well, can be compared against the results from the cost effectiveness of the overall population, so not split down by these different subgroups. And this is what we might do if we're trying to make that comparison here. So we can think about those trade-offs between efficiency and equity. And for scenarios in the southeast and the northwest quadrant, we'd need to think about how much equity and efficiency you'd be willing to forego if a cost ineffective or an intervention that widened inequalities was implemented. So you'd need to think about these trade-offs. And I've put the link in here to the equity dashboard, which enables you to do that. And this is downloadable for free for anyone that's interested in thinking about these trade-offs and having a go. So the last thing I wanted to discuss are additional challenges for equity assessments when using a multi-sector approach. So in addition to the challenge of reflecting, different outcomes across sectors, where additionally trade-offs have had to be made across sectors, we also need to think about equity impacts across sectors. And it may be relevant to consider equity in multiple different outcomes and also opportunity costs. And perhaps, each of those have got different weights in order to think about trade-offs. So we may have a different weight in terms of efficiency and equity in one sector versus another sector, which kind of further complicates things. And even within a single sector, for some sectors, there's no single measure of benefit, such as the QALY, which makes the consideration of equity kind of further complex. And I've indeed been involved in conversations with public health people where they've talked about, for a local authority perspective, actually they don't often have a single outcome of interest for some of the programs they're interested in commissioning. And that makes it really, really complex to think about those trade-offs. And then in addition to that, there may be multiple social variables that are used to generate those groupings, and they themselves may be subject to kind of trade-offs. There may be benefits in some groups and opportunity costs incurred in other groups as well. So just to illustrate some of the kind of complexities in implementation of these techniques. So that's it from me. I've just put some links to some helpful resources there, the equity kind of dashboard, and also there's various bits of tools around as well to help people to kind of think about equity issues. Thanks.
Great, thanks ever so much, Laura. And I think that was another demonstration that we economists are not just there just to calculate costs along people's trials, but we've got some really deep thinking and some really nice kind of issues about trade-offs. Got a couple of questions for you. One of them, I wonder whether Tristan Snowsill wants to make the comment himself. Just give him a second to see if he appears, but if not, I'll just kind of read out the comment he made. It was interesting. So Tristan, I don't know if you're able to come in, but if not, I'll just read out what it says. So he said, the equity consideration around opportunity cost is so interesting because if disinvestment takes the form of raising thresholds for, say, referral treatment or increasing waiting times, they might disproportionately affect the number of already disadvantaged groups. So Laura, I don't know if you wanted to say something.
I mean, I agree. I didn't talk about disinvestment as such, but I agree that that's another whole host of issues around, disinvestment. I was thinking more about investment, but disinvestment, you often find disproportionately it will affect those more disadvantaged groups. Yeah, I think, yeah, I mean, it's a whole, you know, can of worms, isn't it, really? I think it's relevant for us to consider, you know, think about equity and think about trade-offs that we make, and ideally not implement interventions that increase health inequalities. But actually it's massively complex, because we're not even just talking about one measure of inequality here, you know, and even within that we can be, you know, gaining and losing from different sectors of a population. So yeah, no, I don't have an answer, but I agree that it's also a challenge. I don't know if anyone's got the answer to that. Yeah.
Well, we can add it on as the list of something for future research, can't
Yeah.
we? Yeah, we can add it to the list. I suppose we've probably just got time just for John. So John, I think probably John Silcock this is. I don't know whether we'll be able to get John in time, because I think someone has to unmute for it to happen. But John has raised the question, I think it's a serious one, about whether there's any new people looking like community-based results. Oh, here comes John, I think. John, do you want to make the point yourself?
Thanks, Matt. Yeah, I was just wondering if there was anybody looking at community-based approaches to resource allocation, which was something that Gavin Mooney was most famous for, I think. And I just wondered if anyone had taken that up really and was developing those methods as well, because Gavin obviously was one of the prime movers, wasn't he, in incorporating equity in economic evaluation.
Yeah, so there is a reasonable amount of stuff going on here from someone called Richard Cookson, who's done a lot of this stuff, and actually the kind of the equity trade-off stuff and a lot of the material I put up there, that would be, you know, from Richard Cookson. I understand that he's kind of delving into that area. The specifics of what he's doing, I'm not entirely sure, but he has a as well as the equity dashboard, he's got a web page, and I'll find the link to it and I'll put that up, because I'm sure he's talked about community allocation stuff in there as well.
There are these benefits as well, aren't there? Psychic benefits, if you like, from people actually being involved in the decision making, as well as decisions being good decisions. Yes, yeah.
Thanks ever so much, John. In the interest of time, I'm going to keep us moving on. If we get time in the panel session, we can come back to some of these. But the next speaker we've got is Chris Bojke. So Chris is Professor of Health Economics at University of Leeds. And Chris, I think you're going to talk to us about using data or national data and non-randomised data to inform economic analysis. Over to you, Chris. Thanks.
Great, thank you. So hopefully you can see my screen, and hopefully
you can see that fine. Yeah, thanks.
Great, thanks. And it really follows on, I think, from Rachel's excellent talk this morning. So some of the issues that she brought up and some of the questions that came up from that will hopefully be resolved with this little chat. So there's two key things here. It's the routinely available data, and probably most importantly, non-randomized real world data. And I'm going to struggle now to move stuff on. So, okay, so just an outline of what I want to talk about. Just want to introduce some of the types of data that we commonly use in this area and how they're being used, because there are different ways we could use it. Going to outline what the big problem is with using the non-RCT element of this data, and then we'll probably spend quite a bit of time discussing and trying to motivate some of the sophisticated methods that we have to address that. And the key point of this is going to be that whenever you're using non-randomized controlled trial data, you have to have some kind of method to accommodate or the possible biases that you might get. You can't just leave it to chance. And then we'll summarize things at the end there. So what type of data are we looking at? So by routinely, we're really looking at data that's collected for purposes other than analysis. And the big issue with that is that it may not collect all the necessary variables that we'd like to have for economic evaluation. And the key one, as Rachel pointed out this morning, is EQ5D. It's very, very rare that you will come across a routinely collected data set that actually includes EQ5D. But there are benefits of these as well. Sometimes you can actually find some really great detailed information in these data sets that would be very difficult to collect otherwise. And another key benefit for it is that it's being collected over time. So when you do get those situations where you are asked to analyze something after the fact that this data has already been collected doesn't provide any problems with that. So in terms of the type, the ones we commonly used are data that are being primarily collected for payment purposes, and these are things like hospital episode statistics, which contain sort of every patient hospital interaction that occurs in England. And we also now have added to that, it's not commonly known, but all the prescriptions data that is dispensed in the community is also now available from NHS England. Now, there are incredible problems about accessing this data, which I'm going to just completely and utterly gloss over, but you do need to spend quite a bit of time applying for this data and reassuring the providers that you can safely store this data. But these data are national, it's everybody there, so it's very representative. And there are standards imposed on the data, which I think are very important from an analysis point of view as well. So a patient that has gone to York Hospital and had certain procedures done to them in a patient pathway, if they'd instead, say, gone to Manchester and had exactly the same thing happen to them, I would expect those data items to look similar, very similar indeed, if not the same. And because they're used for payment, it's actually really quite easy to start attaching costs, etc., to these things via reference costs, which are also publicly available. We've also got data that is collected for clinical management and some key data sources there you may have heard of: CPRD, GPRD, and Research One. They're primary care systems, so it's a software that GPs, primary care, use to store clinical data about their patients. We also have things like staffing tools in hospitals as well, which may be used to collect these things. Now, these aren't always necessarily representative. They're not national. The primary care systems have a bit of a regional distribution to them. And the most important thing about them is that they're used by individuals for their own purposes. So the coding standards may not be the same. And that makes it a little bit more messy and problematic, I think. So the example I gave of a patient being either in York or Manchester and having the same data recorded in HES, I wouldn't necessarily always expect that I'll be so confident it's true for a York patient in my local primary care centre. Instead, if I'd gone to Manchester, the data may look slightly different. But it is easy to attach generic costs to them as well. There's sort of a PSSRU have data on the average cost of GP surgery consultations, so we can attach that type of data as well. So what do we use the data for? Well, we can actually use it alongside our RCTs as well. I'm very briefly going to gloss over this. So you don't have to just use routine data for where you don't have trials. You can use it alongside trials. And if you're looking at hospitalizations, it actually seems to be a lot better, I think, to be using stuff like HARES, which is very, very, very detailed, doesn't require patient recollection, and we can look at it over extended periods as well. And at the bottom there, there's a little link to a project that we're involved with now called ISCAMAT, which is looking at heart medications, which extensively uses HES instead of trying to elicit responses from patients, but it is in the context of an RCT. There's also a very interesting side of literature emerging now, which is using routine data to supplement RCTs, called target trial emulation, which is looking to see whether if we impose inclusion-exclusion criteria on observational data, do we get what we see in the trials? And if so, can we expand what we get from that to using to forming expectations on people not included in trials? But the big thing we're really going to concentrate on here is using routine data instead of RCTs. And that means we're going to be using the routine data to try and estimate causality. And the big problem we have is that as soon as you move away from RCTs, you're suddenly at risk of creating biases in your estimates, mainly due to the impact of unobserved factors which influence treatment as well as outcomes. And as I said very early on, what we really need is some sort of specific identification strategy to account for this potential bias. Okay, so what is the danger? And there's three questions we really need to ask ourselves here. Is the treatment allocation random or systematic? And this is a very, very important point, because ultimately what we're going to say is that random variation is good, systematic variation can lead to sort of biases. It's a bit Animal Farm, there's two legs bad, four legs good, but in practice, the use of random allocation to identify effect is good, and systematic can cloud our understanding of the true effect. If we do have systematic variation in treatment allocation, we need to ask ourselves, is it related to the expected outcomes of of factors that can influence outcomes as well? And if so, is there some way of observing or otherwise controlling for these factors? And we can ask ourselves 2 supplement questions when we get to 3. Is there some way we can separate out random and systematic variation? Or can we exploit the timing of discrete interventions and try and control for differences by using sort of before and after data? And if we arrive at no at the end of question 3, then we've really got to be concerned that any use of routine data is going to lead to biased estimates of effect. And the main source of this is what we call omitted variable bias. So, for example, if a variable, like say frailty, is unobserved, but also strongly positively correlated with the treatment choice, but is also likely to cause worse outcomes in general, then we're going to underestimate the impact of the treatment, as it will be contaminated by the uncontrolled impact of frailty. So if frail patients tend to get one type of treatment more than another, even if that treatment has a very positive effect, unless you account for the underlying effect of frailty itself, we're going to get biased outcomes. And depending on the strength of the relationships, we may even get results which go in completely the wrong direction. And the impact will be in the other direction if the correlation is the other way around. So if better sort of patients are likely to get the treatment, might overestimate the impact. And the key thing to understand here is that RCTs ensure the correlation doesn't occur. So with RCTs, we're not arguing that there isn't other factors that influence results, but in order for us to have biased estimates, there has to be a correlation between those factors and treatment allocation. An RCT nips that in the bud straight away. It ensures that correlation doesn't occur, so we're safe to just look at, say, comparisons of means. Okay, so I've raced through all of that. Hopefully you're still following me. In order to get down to, I think, the more interesting components of this talk, which is how do we then identify causality? And my thing seems to stop working. Oh. Okay, so that should do it. Yeah, okay. So almost all the methods that we look either try to account for underlying differences between experimental units, if you like, and or identify the use of random rather than systematic variation. So, but either way, what we're going to need is some very explicit identification strategy. We can't just do a comparison of means or put in a very simple regression model. We're going to need to say exactly how we intend to avoid the potential bias here. And the common ways we can do this, we can often exploit longitudinal data and an intervention occurring in time in some of what we consider experimental units. So this is going to hopefully answer Felicity's question from earlier on this morning. Sometimes we don't have this occurrence happening, so then we have to try and use other techniques which ultimately have to rely on some very happy coincidence in the data that generate some random variation in treatment allocation. And really, really importantly, and I think this is underdone a little bit in practice, we really do need to explore the plausibility of these strategies as best we can and understand the consequences for the results where we feel they may not be satisfied. So let's look at some of the evaluation techniques that exploit time. So one of the key ones, and you may have heard of this, is a difference in difference approach. And what we have here, and hopefully you can see my little arrow, is that you have 2 groups. One group are subjected to an intervention and a control group which aren't. Now, and you have 2 points of observation, a pre-intervention period and a post-intervention period, so quite limited. And if we look at the left-hand side of this graph here, if the outcomes are, say, positive, you can see the group that are subjected to the intervention at some point generally have better outcomes than the group who aren't. Now, you would, of course, not expect to see this in an RCT. So we've got this uneven sort of allocation here. We've got allocation of the treatment to the group that tend to have better outcomes anyway. Then at post-intervention, at some point, we take another measurement, and we see that those who were in the intervention group have improved their outcomes to here, and those in the control group have just improved their outcomes to here. Now, we may be tempted to compare the outcomes in the intervention group from here to what they were and estimate the effect here. But this ignores the fact that actually, even without an intervention, there probably would have been an increase in good outcomes. And what we do is we take what we've measured here, the general trend, and we assume it would have happened to those in the intervention group as well, allowing for this constant difference here. So the intervention effect is actually what we measure here. Now, this makes a very, very strong assumption of parallel trends, that what would have happened to this group here is captured by the difference in this group here. So hence the difference in difference. So that's reasonable, but it makes a very strong assumption. We've also got something called interrupted time series, which doesn't bother with a control group. You might have practices or units where we observe, say, hospitalizations over time, and then at some point there is an intervention occurs. And what we can do is we can set up a mathematical model that captures the trend specifically. So instead of assuming really what the trend was for this group, the intervention group, we measure it. And then when the intervention occurs, we may observe a drop in the outcome measure and then a change in slope as well. And I quite like this graph because what it does very clearly is it maps the mathematical model to the concepts here. But the big problem with this one, of course, is that there's no control group. So you have to hope, keep your fingers crossed, that actually nothing occurred here, which also affects outcomes, and that we get confused with. And there is an alternative approach, which is called the controlled interrupted time series, which brings both of these elements together. So you have control and intervention, and you allow for the trend to change as well for the observed group, as well as the counterfactual. And this allows you to compare the two and actually make a much more robust estimate on what the intervention effect was. So if we consider all of these things, the difference in difference, it does have a control group, but it has 2 time points and makes very strong assumptions about trend. The interrupted time series doesn't have a control group. You can measure trend, but you have to keep your fingers crossed nothing else has happened. Whereas these controlled interrupted time series does have a control group. It allows for the differences between them, and actually it allows for something else to happen here, which impacts the control as well as the intervention. It allows you to unpick all of these things. So if we just very quickly look at an example for this, several years ago, Laura, Gerry, and myself and another colleague who's at York, Anna Duarte, were asked to look at the impact of care hubs in York. Care hubs are these models of integrated care systems which are meant to improve patient experience for those at high risk of hospitalization. There were 3 pilot schemes launched in 2014 in York, involving 13 of the Vale's practices. At some point after that, we were asked to analyze whether it had any effect on hospitalizations. So we used the HES data collected on all 29 practices for those 3 years. We also took from routinely available data the practice list sizes, which contained the population measures in age and sex categories. And we could work out the proportion of elderly patients experiencing hospital episodes month by month for each practice. So this is a spaghetti plot. I know these things look horrendous, but they are actually quite informative. The solid lines are practices that eventually became part of the care hubs. The dashed lines are those who don't. And what you can see is actually at the beginning of the graph, they're all intermingled. So it's not as if actually the practices that started the care hubs had necessarily high rates. And if we look at the end of the graph, it's not as if we see the solid lines diverging from those of the dash. So just a casual inspection of that graph suggests there hasn't been much impact. And actually, when we start doing the formal models, it's really just about a bit more formal measurement of these types of data. So those graphs are quite informative. The available data we have suggests a controlled interrupted time series. The data are a bit awkward in terms of their outcomes. So we used a Poisson count model adjusted for the population. And we also did something to account for practice level differences in the underlying rates as well. And what we found is, I'm going to have to speed it a bit because I haven't timed this particularly well, I apologize. For various age groups, There were differences between them. So if you're female, 55, more negative means less likely to. As you go up the age groups, it gets more positive and therefore you're more likely. So that's got face validity. There was absolutely no evidence really of a time trend apart from a very small one for female, but very, very small. And here's what we're really interested in here. If the care hubs had had the impact we'd expect, these would all be negative and hopefully statistically significant, as with these. And what we actually find is that there wasn't really any great evidence of the impact as intended. In fact, if anything, it seemed to be suggesting that the care hubs created more hospitalizations. What we can also do is we can convert these kind of abstract regression results into expectations. So we can take our data sets and we can say, what would we have expected if they hadn't introduced care hubs at all? And what we actually found was with care hubs, there's about 101,000 hospitalizations. If they hadn't put those 13, of those 13 practices hadn't done the care hubs, we would have expected about 100,000. So we could conclude from that, rather kind of quick and dirty analysis, in a very quick time period, having accounted for the routine nature, that actually we didn't find compelling evidence that the care hub pilots worked at all. And indeed, they're no longer in place. So that time you might use the time element. Often we don't have that luxury, and in which case we've got to try and observe. We've got to try and find a method which distinguishes between random variation and systematic variation, and just use that random variation in the regression models. And the most common way of doing that is something called instrumental variables. It's actually been around since the 1920s formally. And it requires a lucky identification of something that influences treatment allocation, but not the outcomes themselves, but is also not influenced by unobserved confounders. There's a nice little graph here that illustrates that. So you want to find some sort of variable which influences the treatment, and we think the treatment influences outcome, but the instrument doesn't directly affect the outcomes, nor is it affected by the unobserved outcomes. And I've quickly put in a little picture of up here of John Snow, who, although isn't really attributed with inventing instrumental variables, I think illustrates this path very nicely. So in the 1850s in London, there was a big cholera outbreak, lots of deaths, etc. And what John managed to sort of figure out was that the water supply via pumps was randomly distributed across London. So we couldn't measure sort of the water pollution, but what he could do is find out who served, which water pumps served which areas. It was also the case that actually rich areas had didn't have certain water providers that were kind of higgledy-piggledy randomly allocated, rather than rich areas having one water supplier and poorer areas having the other. And what he discovered was by using water suppliers as an instrument, he was able to demonstrate the effect there, just after allowing for unobserved confounders, and because choice of water provider didn't have any impact on outcome, other than because of its, the exposure to water pollution, because different water providers drew their water from different places in the Thames. So those that did it before London tended to have clearer water, and those after had the polluted one. So they've been used in medical literature really from about 1990. There's a classic example here in Journal of American Medical Association. So obviously past peer review here. I'm thinking at the use of intensive treatments like aggressive use of cardiac catheterization to reduce mortality. The big issue here is that do they only really give intensive treatments to those patients who seem more robust? And so is it really the intensive treatment that's leading to longer life expectancy, or is it the fact it's just this non-random selection of patients? We can't use the time series approaches because of the data. So what the authors used were patient distances from alternative types of hospitals that specialize more in intensive treatments as their instrument. And this is the sort of thing that we could do with HES linked to ONS as well. And what they found was using this as an instrument is happy coincidence, because those who were closest to those hospitals tended to receive those types of treatments, that actually using this instrumental variable approach, they found that the estimates decreased from using the naive approach and that the survival benefits from the greater use of catheterization appeared absolutely minimal. Okay, so in practice, it's often very difficult to get good instruments, and we often tend to use weak ones. So what I mean by weak is this relationship isn't particularly strong. We tend not to really, we can't formally test some key assumptions like this one here, because these things are unobserved. There has been a bit of a resurgence, I think, in the use of IVs because of this new type known as tendency to operate, where the variation is being, the random variation is being picked up by underlying preferences for one treatment over another. So given a patient's characteristic, one hospital or doctor or clinician or whatever might say, well, we think this treatment, and another one with exactly that same patient might say, we recommend a different one. And it's this type of underlying preference which introduces this kind of element of randomness into the treatment allocation, which can be exploited as an instrumental variable. It does rely on this variation being pure preference and not skill, which might be a bit suspect. But for those of you who are interested, NIHR has just, well, a couple of years ago, funded a study which uses precisely these measurements, which looks at the use of emergency surgery in A&E. I think Matt was the deputy chair when that was funded. So you can follow that up to see how modern IVs are being used here. I'm not going to talk about this because I think I've run out of time. I'm just going to drop straight to summary. So there are a large number of routine data sets around which cover a lot of the things that we're interested in. Although they're not built for analysis, they are extremely useful source of complete and often very, very detailed information that we might not even be able to get if we tried to collect this thing prospectively. There's actually an increasing recognition of the value that such data can bring to analysis, and it's very interesting now that NICE have actually expressed a commitment to using more real-world data in the evidence base, and there's actually going to be a launch of their real-world evidence framework in June, so we've still got time to get yourself registered for that if you so wish. But although I agree, I think it's very, very useful, and I've sort of built my career around this. Whilst we can use these data to identify the causal relationships we need to inform economic evaluation, it's absolutely vital that we have some explicit identification strategy in place to try and avoid it, to avoid the biases that can be caused by omitted variables. And I've gone through some of them that you can look up. So I think continuous interrupted time series is very good where it can be used. It's probably state of the art. And instrumental variables are the other key tool that we have where we can't exploit differences over time. And I think the tendency to operate is a very exciting extension of that. But what we really need to be absolutely on the ball with, I think, is that we shouldn't be seduced by the sophistication of some of these methods. I mean, we really need to be absolutely critical of the results that we get from them and exploring whether those crucial assumptions are actually met. Okay, I think I want to stop there for any questions. Apologies, but there was an awful lot to try and cram into that small session, so hopefully I haven't gone too fast. And like we said before, the slides are available to pore over later, and hopefully you have enough references in there to chase up things after the presentations. Thank you.
Fabulous, thanks, Chris. That was great, and I think all the references and the further guidance you've given people was really, really helpful. A lot of that I didn't know about, so I'll be following up on those. There is a question specific for you, but it's about dealing with the sort of COVID interruptions. And what I'm proposing to do is we put that into the panel discussion, because I'm interested to hear other people's kind of experiences of sort of how they are sort of recrafting their work given the changes that came about with COVID. So can I kind of bring just everyone straight back into panel session? Is that all right? And I will pick up it's Lisa Cummins' COVID question as part of that. So yeah, could I ask people on the panel just to come back in, please, if you could? Okay, can I have a first go on that one then, since I'm already on? That'd be great. Yeah, Chris, if you want. I think it's a really excellent question, and it's something I thought about a lot, and I almost put in a slide on it, but I already had too many, as demonstrated. I think you've got two sorts of people in the world. Some who think that this COVID is some sort of natural experiment which allows us to have
exogenous variation and things which can be exploited to understand impacts, and you have the other sort, which I very much put myself in, and think that it creates an incredible amount of confusion and noise in the data set, which hugely complicates anything we're going to do. So personally, I feel a bit pessimistic about you really using the observational data over the recent period. I think we're just going to have this gap in time where we could be using these routine data sets.
Thanks, Chris. Does anybody else want to come in and talk about how they are coping with the COVID period? I say as if it's over, but Laura, are you trying to get in? Yeah, please.
Yeah, I've had conversations recently around resource utilization and the fact that, you know, people are generally going to hospital less, you know, consulting with healthcare professionals less, and whether or not you would be able to conclude something around potential cost savings of an intervention because of COVID. And we did, you know, contemplate, this is an issue for, you know, all health economic evaluations. This is not unique to that specific application, whether or not we sought from the likes of NIHR guidance on, you know, what is our reference point. So I think that's the key thing. Is, are we thinking about savings compared to the, you know, status quo kind of pre-COVID? Are we thinking about now we're in a situation whereby people perhaps, you know, consult with healthcare professionals less or do things more remotely? You know, what is our kind of reference point to have a clear steer from the likes of NIHR? We ended up, you know, not getting up the guts to kind of put that letter together, but we felt that it was a general issue for all kind of economic evaluation. What do we do with all this data we've collected for the last couple of years? How do we actually make any conclusions about whether or not things are cost effective? Yeah.
Just to add to that, Laura, the intervention itself is often different because it can't be delivered face to face or in a group. The interventions as they were originally intended aren't delivered in that way. So it becomes even more. It's not just cost effectiveness; it's effectiveness.
Thanks, Gerry. Does anybody else want to come in this, or shall I move on to the next? We collected up 2 or 3 questions. So does anybody else want to come in? Oh, Claire, yeah. Clara, sorry, yeah.
Yeah, I was going to say the other thing is outcomes, and outcomes that have been collected within the process, you know, during the COVID period, and when people are answering questionnaires that ask them about their health or their well-being, and it's being impacted by the pandemic. So, like separating out what's the impact of pandemic and what's the impact of an intervention or condition. That is one of the things that has been an issue. And related is the issue of values or the tariff that you attach to outcome measures. So the tariff that we currently use for EQ5D is from the 90s. And there's a question about preferences and whether they've changed. So the re-evaluation for the UK, the second study, because there's already one that's been sort of not accepted, is due to happen from this year. And then there's a question of, is that like reflecting sort of pandemic issues, and how do you deal with that anyway? If it is, how do you deal with that?
Yeah, thanks, Clara. Yeah, we mustn't forget that there's, yes, the way in which we sort of value the benefits as well as how what benefits we measure will also change with the context, which I think was the point I think that Matt was making in a lot of his talk as well, about the context is very important. Okay, I'm going to move us on to one of the general questions, which was from Chris Albertin. And he said it was a sort of broader question for today. But how do we sort of adapt economic evaluation when you consider the interplay between NHS and social care services? And they might be council or private owned, so not standardised costings. And I suppose he was saying, as an ageing dementia researcher, this comes up a lot. So who wants to take the lead on this one for us about looking at social care as well as NHS services? You all have been warned, so you can't duck this one. Well, Chris, what we can say so far is this is a relatively new topic, and the economists are learning how to take account of social care. I think that's definitely going to be the case. But does anybody want to come in?
Well, Matt, I'm trying to think whether anything came up at the event that we held recently when we were talking about different evidence users.
Yeah, I mean, I certainly think we were made very aware of the fact that we are dealing with a very different context here, and some of we are going to have to change our methods considerably. We can't just pick up a new set of unit costs and apply those. I can see Matt might want to come in. So Matt, do you want to, and then Laura? Yeah, please.
I've read the question over a couple of times now, and there's a lot of ways to do this, but I'm going to do it a couple of ways. Firstly, in terms of, because I've been doing some work with social care services, I'm talking to local authorities. One aspect which we've got a problem with, particularly with social care services, and when we're interested in using routine data, is that social care data doesn't really have the necessary metadata to be able to tell us what actually is being collected in social care data. You're seeing a few databases in a regional sense rather than national sense trying to collect social care data, which we could then use to inform our analyses. But even those that are getting the data, when you talk to them, have said, we can't really come from a perspective of looking at the data and going, right, this is what you're collecting, this is what we're going to use. They quite often go, right, we're collecting all this, you're going to have to go through everything with the informatics specialist and talk through it. So it's a really complicated job. So a particular thing to do with, if we're going to start looking between the NHS and social care services, is this introduction of practices we've introduced within the NHS, which is developing metadata, having data dictionaries, having it properly laid out, and then having methods for accessing the data so we can actually start to use it in our practices. Because otherwise we're completely reliant on negotiations with health informatics specialists in local areas, which is time consuming and complicated, or primary data collection. And those that use social care services, if you're doing primary data collection, for example, if I put out a survey to older people, there's problems there with recall bias and cognitive burden and so on and so forth. So from a data perspective, at least, there needs to be further investment in metadata and data systems, social care. Otherwise, we don't really know what's there to use.
Yeah, thanks, Matt. And one of the things we did here at this this sort of roundtable event we held a couple of weeks ago was that actually they do think the social care data is improving rapidly, particularly in response to COVID. That actually a lot of the data collection systems in social care have improved, and I think they were saying from April next year we should expect quite a big change in availability, but we shall see. We've all been here before. Laura, please.
Yeah, I was just going to say that I think one of the main challenges in social care and evaluation is not having a clear objective function. There are multiple different outcomes of interest. It differs by, what population you're thinking about with regards to social care. So actually, the data and the evaluation side of stuff can't really progress until we know what it is we're trying to maximize, and I kind of struggle with that. And then beyond that, do we have a good way of kind of measuring those things and thinking about trade-offs? And I feel until we've kind of bottomed that out, we just keep going round and round in circles. But I don't know, maybe other people know what we're trying to maximize in social care. I don't know. Maybe I missed out.
Rachel, you wanted to come in next.
Well, I suppose, it was just reading the question back, and I suppose the question was, how is economic evaluation impacted when we consider the interplay between these services? And I suppose a key thing is that we widen our perspective. So when we're looking at kind of health interventions, we tend to be looking at the impact on the health service. And as Laura's indicated, I suppose we need to look at wider outcomes, because different funders are concerned about maximising different outcomes. And then we also need to widen the perspective about where the costs fall. And I think, we don't have an answer yet of how to combine that all into one metric to say, okay, here's your overall measure of costs, and here's your overall measure of benefits. So some people do things like cost consequences analysis, where you kind of list your outcomes on multiple measures. So we might have, well, here's the impact on health, here's the impact on well-being, which might be more important in social care, maybe here's the impact on something else. We kind of list the costs that fall on different budgets, but then we kind of stop and we don't really make a recommendation about the decision, and that's up to the decision maker. But I think there's a long way to go in this area, so I don't think anyone's going to have an easy answer for you.
Thanks, Rachel. I can see that Chris Todd has suggested that Martin Knapp's group's coming here, and I think we're all conscious of the fact that the amount of strain that's been put on Martin and his colleagues' expertise in social care. I think we're all going to have to become experts in social care. We can't always rely on Martin. But Matt, do you want to come in and make the last comment on this, and I'll move us on to the next?
It was really building on what Laura was saying. So we can reflect on at least two measures and a different framework. So sense capability-based framework and capability-based measures like the ASCOT and the ICAP, they don't fit into a maximand. So number one, they don't fit into a quality framework, and they don't fit into a maximand. There's the argument with the capability-based framework that what we're trying to achieve is sufficient capability. That is that we don't want to maximize people to do everything, but we have an idea that people should be able to achieve a sufficient level of quality of life. So the ability to feel love, the ability to feel enjoyment. And we don't want people to have all the love and all the enjoyment ever. We don't want to consume it completely, but they should have a sufficient level. And this is kind of been applied in social care and fits into a different framework. The probability with capability-based measures and the capability-based approaches is difficult to operationalize, and it doesn't fit into our nice maximizing qualities framework. It sits very different, but there's a lot of work going on there, and it's really interesting.
Thanks, Matt. One of the other comments we got was from Asan Akpan, who said he would love to do an economic evaluation of his input as a community geriatrician, and he asked for suggestions on who might he want to collaborate with, how would he make that possible, how would he find the sort of funding for the time of a health economist, or would anyone here actually particularly be interested? Gerry, I suspect you're going to pick up some of those issues in your talk, which sort of advises people on how to access resources. But does anybody just want to make any comment about economic evaluation of community geriatrician role? Has anyone done work or know of work that's similar that Asan might be able to access? It's a very nice kind of sort of mega question, if you like. It's not a specific intervention, but more of the value of an entire work or a new way of working, which I think is, again, is a nice thing for the economists to take on.
Yeah, I can just say quickly, Mark, I mean, there's been a fair bit of trial-based work, but a lot of it outside of the UK in terms of, well, interventions shaped around community geriatric, geriatrician involvement, but probably less so in a kind of UK service context, kind of linking back to the, I suppose, Rachel's talk, as I would have thought in terms of the relevance. So it probably is a bit of a gap. And again, there has been trial-based work in the UK quite recently, looking at things like hospital at home, discharge to assess, models for delivering what we call comprehensive geriatric assessments. So there's been a fair bit of trial-based work, but probably less I would have thought about what Asan's referring to. I can sort of picture what he's referring to. So I think it probably is a gap in the kind of UK service context, I think.
Thanks, Andy. Let me just finish up. So Gerry Richardson's going to give us the final talk, sort of advising on sort of signposting people to where to go. But one of the things which I did ask people to have a think about was kind of what they see as the most exciting opportunities, kind of doing economics in ageing and frailty. So we sort of asked you to all to sort of think about how the work you do relates to ageing and frailty, but there are things along the way that you thought, oh, this is a really exciting opportunity for economists kind of to get involved in. So does anybody want to jump in on that? Yes, Matt, please.
I'll bring one thing in, given that Andy's on the call. The electronic frailty index and the ability to quantify frailty and to have it as when I'm doing stats, kind of metrics, I obviously need to quantify stuff. And I used to work in older people before, but the ability to now quantify frailty status, particularly in routine data like primary care data sets, opens up a whole range of possibilities. So I'll be using the Care 75 Plus cohort to start estimating utility values, to do with frailty, so that frailty can be better included in economic evaluation models. And that's just one option. But this kind of routine data analysis, which Chris is talking about using primary care data, now that we can quantify the EFI within this routine data, it means we can actually start doing this analysis using routine data. So that movement to the ability to quantify frailty is just a massive step. And I think you're going to see a lot more research now that we can do that. And I think you'll see people moving away from this paradigm focused on age to focused on frailty.
Thanks. Andy, did you want to come in?
Yeah, I mean, I think there's opportunities relating to everybody's talks. I mean, if I was going to probably pick something specific, actually, the area where it felt like there was the biggest gap was probably maybe around sort of equity considerations, I think, and how they relate to older people, because it's so complicated, but so important. So it felt like that is something that there's huge potential. But I think there is sort of across the board, as there often is in ageing, frailty, dementia related research, there are often many gaps that are sort of ripe for new research, actually.
Does anybody else want to come in, or yes, Chris, please?
Well, just to build on Matt's point as well, I think that measurement really does give us a whole new set of areas to explore as well, and interesting questions. So, for example, should evaluations be targeted at reducing the how frailty develops over time, for example, should they be targeted to lessening the impact of given level of frailty? So I think there's really interesting questions. And I think it also allows us to start talking about heterogeneity a lot more as well. So I think a huge number of exciting possibilities there.
Thanks. Okay, well, in the interest of time, Gerry, do you want to give us your signpostings as to how we can...
Love to, Matt. Yes, thank you. I'll try sharing my screen. So, is that working? You're on mute now, Matt, but yes, that's fine. Right. So you've had quite a lot of talks about health economics and what we can do. This is going to be a lot. It's going to be a lot more light. I think this is not that there's going to be any gags in it, but it will be a lot lighter than the previous presentations. I'm going to talk a little bit about how you might access health economics advice and support, but more generally about all support for applications, proposals going forward. Okay, so I'm particularly going to talk about the RDS, which is the Research Design Service. There are 10 RDSs across the country, and unfortunately they don't fit in, they don't align completely with the ARCs, of which there are 15. The ones at the top, the northern ones, do tend to align, but the ones further south don't. The purpose of the RDS is to offer a fit-for-purpose advice and support on research design and methodology to researchers making funding applications. The idea originally was to support applications to the research for benefit, patient benefit funding stream of NIHR, to increase the number and proportion of those. There was a feeling that the applications going into that funding stream in particular weren't particularly great quality, and they wanted to improve that. I think that's happened, and I think that also the remit of RDS has been expanded. So we now support not just RFPB, but all NIHR and indeed some charitable applications. There's an idea that there should be a consistent national coverage for these programs. So what's the value of the RDS? Well, I think one of the top one is probably the most important. It's a critical friend to help you consider all the issues that might arise with your proposal at an early stage. We might also discuss the best method to answer your research question, whether that be, for example, a trial or some sort of analysis like Chris Bojke was talking about earlier. Meet and build relationships with experts in the field. So it may be that you don't have a health economist or a statistician, but that the RDS can point you in the direction of someone who can help you out. I think one of the most crucial things is that most RDS people sit on or observe funding panels, and they sort of get a feeling for the zeitgeist, if you like. So what's going on? What makes those panels tick? What makes them fund particular things and not fund particular other things? What sort of makeup of a team they're looking for, and so on. So I think that is really crucially important, and it does give you a real advantage to know what your funding panel or funding stream is looking for. Also, unfortunately, most of them are very well aware of the application process and the onerous nature of it, so they will have been through that process, and then they'll probably know who you need to talk to if and when you hit a problem. We also assess readiness to submit. So quite frequently we will get people coming to us with I'm going to submit this in 2 weeks. What do you think? And quite often the advice coming back would be, I don't really think it's ready to submit in 2 weeks. Why wouldn't you wait for another till the next call comes out in 3 or 4 months? And also with the application reviews, you get a structured feedback. So whenever we receive an application, we will go through it with a fine-tooth comb and provide a detailed email about how you might address particular issues. So adding value, we talk about things like questions that are relevant to clinicians and patients. So try and avoid low priority ones and sort of not big up necessarily, but state the importance of the problem. Ensure that appropriate design and methods are used. So it says here that 50% of studies are designed without reference to a systematic review. That's it's not shocking, but it's a negative when it comes to funding panels. So if people are aware that there is a systematic review out there and that hasn't been referenced or included, then that's seen as a negative. We'd like to see accessible full publication. So we really just want to ensure that studies do get published. A lot of studies don't. A lot of them just fall by the wayside because they have a null result, or they are deemed it is not feasible, and that's not seen as a particularly interesting result. But that's biased, I think. And we want to see ultimately a usable report. So ultimately, this boils down to reducing research waste. So we want to have better and more research, and we want to reduce the amount of research waste. So the RDS helps with all sorts of things. Literature reviews, we can help you out with how to do one. We can look at funding streams and give advice, and we quite frequently do give advice on the appropriate funding stream. So it may well be that within NIHR there are several potential funding streams available, and sometimes we can't answer the question of which is the most appropriate. It may be that there are several. And it then becomes a case of, we advise you to talk to the program manager or the respective people at the relative funding stream, relevant funding stream, who can talk you through that. But we do talk about appropriate funding streams. We do talk about study design, as I said before, whether it's RCT or qualitative research or whatever. We can talk you through that. Feasibility, we do quite a lot of feasibility work, I think, particularly because a lot of the work we do is still around RFPB and is still around the entry level, if you like, research. So we get a lot of people who haven't got a particularly strong NIHR track record, and a lot of the time the easiest way in, or a common way in, is to look at a feasibility study for RFPB, which has some funding and gets you on the sort of the trajectory to being an NIHR researcher. The involvement of patients and public is absolutely key. I mean, I can't emphasize that enough. And I think as health economists, historically, that's something that we perhaps haven't paid that much attention to, but now is absolutely, it's pretty much mandatory for NIHR applications. And it's not just involving the patients and public, it's making sure that involvement is meaningful and appropriate, and that it's not just tokenistic. So you do see, or historically have seen, examples where PPI is included, but it really is just a case of putting Joe Blogs on who's a patient and in the public, who'll talk to us. But it doesn't really, it's tokenistic and not really very meaningful. Of course, the research team we can talk about, and obviously that does include health economists. So some of the time we can signpost you to health economists, statisticians, and whatever. I think there is there are health economists on each of the RDS in each of the RDS areas, but I'm not absolutely certain about that. But they should all be aware of health economists and other people that you would need to help you in your research team. Ethical considerations, obviously, I have very little to do with that. I'm aware of them, and I will point people to the relevant people in York or elsewhere. And we can also talk a little bit about impact. We have our impact research champion is actually based at York, Alison Booth, so she's happy to talk about issues of impact. So what the RDS does not do, What we don't do, thankfully for me, but probably unfortunately for you, is write the application protocols. We do get people coming to us and saying, we say, you need a health economist, you need a statistician, you need someone to do the systematic review. And the clinician, for example, may say, who do I get to write that? And that's where it's sort of, there's a bit of a gap there, because we don't do that and the clinician doesn't have time to do that. So that is an ongoing issue, but that's something that the RDS don't do. We don't help with projects where there's no intention of submitting, and we don't support applications that are not research, such as audit. Sometimes I appreciate that the line between research and audit is maybe slightly blurred, but there has to be ultimately a research question that we can address. We don't provide supervision or informal support for students, and we don't continue to support applications where the work has remained unchanged from previous submitted versions. But having said that, if it's tweaked to be more suitable for a different funding stream, we will of course consider that. Working with the RDS, I'd say book an early appointment with the RDS with a summary of one side of A4. The way that it will work is that we'll put face-to-face meeting there. Actually, these are older slides, and these are probably pre-COVID. Now, obviously, it may well be a Zoom meeting, and I don't know what it's going to look like in a year or 2 years' time. But what I mean by that is a one-to-one meeting where you'll first meet with a generalist who has a general knowledge of the research environment, but then we'll follow up with specialist people, health economists, statisticians, and so on, who will review your application and say whether it's strong enough or it needs more work in that area. I'm going to skip that because there's an awful lot going on in there. Initial meeting with the RDS, we will talk about the importance of the question, potential funding streams, again, study design, clinical area, the feasibility of the recruitment strategy. So one thing that panels do pick up on a lot is when people say that they're going to recruit X number of people, panels do pick up on whether that is actually feasible, and if it's not, that's a big negative. Track record of the team, and clearly that varies according to the funding stream that you're going for. PPI, as I've said, is pretty much mandatory and has to be in there. We'll also talk about costs, research, support, treatment, and excess treatment costs. I'm going to leave it there because it's 1 o'clock. That's my contact details if you've got any queries on anything RDS related. There's also, this is the RDS for Yorkshire and Humber, which does have some useful resources that you might want to tap into that you can find there. But I will leave it there because it's gone 1 o'clock.
No, that's fabulous, Gerry. Thank you very much. And you started a bit late, so you were on time. Don't worry about that. I'm going to hand back to Andy now, but I will just conclude by saying I really enjoyed it. I think it was a great idea to put this together, and I think the speakers have all done fabulous jobs. So I think well done to Andy and well done to everyone. But Andy, it's your last word, so I'll leave it to you.
Yeah, thanks, Matt. Well, I'll just echo what you've just said, actually. And I think David actually captured it in his comment that he put in. I think he wrote, it's rare one sees the length and breadth of a field in one session, from definitions to cutting edge research. And I think that captures it perfectly, actually. And that's down to the speakers and your expert chairing, Matt. But I mean, the speakers particularly, and the way that they coordinated their talks between each other just made it sort of run seamlessly. So big thanks to everyone. And then also the people that have made it work behind the scenes. So the people at the Yorkshire and Humber ARC, James, Shahima, Amy, Katie, just want to say a special thanks to them as well for making things run so smoothly. So we'll be, as I said, we've recorded it. We'll be making the recording available, and the slides I think we can put together and distribute as well. So finally, thanks to everybody for joining us today. Really, really interesting discussions, and thanks for being so engaged. Thanks everybody. We'll see you soon.